Okay, let's begin. Shubham, Praveen, can we start? We are on time.
Yes, sir. We are live now.
And how do I see the students' messages when they come on Zoom? Or do I see it on YouTube? Okay, so good morning, everyone. Hope you're all doing well. I know exams are close by and I know time is crucial, so I won't waste any time. The target today is to complete most of the IMP topics from surgery for FMG. Okay, obviously, surgery is not a subject that can be completed in one day, but I'm hoping most of you have some backing. At least you've had studied surgery from somewhere, if not from me. So, what my aim is going to be today's class is in three parts. In the first part, we are going to do GIT and HPB. Whatever spills over, we'll do that in the second part, where we'll also do trauma and breast endocrine. And in the last part, we will do urology and general surgery. So, that is the schedule that I have lined up for you. Very important thing that I will tell you now that you should listen to. Good morning, all of you. Before I begin, very important critical thing. A few things that you should know. The first is if you have studied from me before or you've been using surgery for cerebellum, then you don't really need to write anything. Just listen. Okay, and avoid asking too many things. So let the flow keep going. The more you interrupt, the lesser you'll be able to achieve. So avoid interruption as much as possible. Let the flow keep going. Okay, you don't really need to write. You won't even need this PDF. You don't even need it if you have studied from me before, because it will all be there in what we have done before. If you are learning from me for the first time ever, then whatever we teach, whatever we discuss today, either add it to your main notes or use this as a base. You can do it either ways. So don't worry, just listen so that I can teach you most of the things that I have lined up. Because I have been given a very limited time, there is only so much I can do. Second thing is in FMG, you are going to get between 30 to 35 questions in surgery straight away. The second section, which is the clinical questions, 150 questions, उसमें से at least 30 to 35 are going to be general surgery. My aim today is out of those 35 questions, at least 15 topics we will discuss today that will feature in your exam. So if you just listen, revise with me, I guarantee it at least 15 or so topics will feature out of those 30 questions, which is amazing, right? So I always tell my students that after doing surgery from me, in your main exam, your burden from surgery should reduce and your burden of other subjects will automatically reduce. Because your target, if it is 150, 170, 180, surgery, if you get 20, 25 questions, then nothing like it, right? So that is the aim that I try to do. I will be discussing PYQs also, so don't worry. I have lined up PYQs as we do the topic, so you will know what questions have been coming. But listen and avoid interruption as much as possible. Okay, because in this much time, how much will I be able to achieve is on your cooperation. And I will give you breaks beach mein. So you have a lunch break at 2, but I'll give you one break before that also, right? So let us begin. Listen, revise as I go, and whatever time you have left in the day, go through whatever we did today or what you've been doing before. कोई एक जगह से you revise. And if you can't revise, once the marathons are over, then also you can do it. Right? So don't worry about it. Today's job is to listen without getting tired. You get tired, have coffee, walk around, 1-2 minutes chutega, it's fine. If I can do at my age a 10-12 hour class, you can listen also. Yesterday also your class got over at 5:45. So yesterday you got some breathing space. So today you can aram say enjoy your weekend with me. Right? So let's begin. Now in GIT, how I'm going to teach you is first we are going to do GI cancers. Okay, because they are the most important. They are a little confusing. First we will revise the GI cancers. Then we will do benign diseases. Then we will do acute abdomen. ऐसे करेंगे because in exam question will come like this. Okay, so in exam the question will not tell you, okay, I am from esophagus, okay, I am from stomach, okay, I am from small bowel appendix. It will come as a scenario most probably. So I will teach you in that scenario pattern. Okay, like a group of diseases and not individual karke. All right. So this is the list of IMP topics. You can take it down from the PDF later. You must be already having the PDF. It was shared. Now we start with the cancers. Now what you need to understand in cancer, there are some very specific things which they always ask. And we will do it in the system like I've always been teaching you. But today we will do it compare karke. So one after another. So it will make little more sense than if it already didn't. So first we start with CA esophagus. And side by side we are going to do CA stomach. And please don't mind my handwriting. My handwriting is much better than a lot of people. So don't mind it and don't mind this pen. Okay, you must be used to it by now if you have been attending my class. CA esophagus, CA stomach, colon, rectum. All GI cancers are bad cancers. Why are they bad cancers? Because they present very late. Okay. And most of the GI cancers are adenocarcinomas except esophagus. In esophagus, you can get squamous cell carcinoma, which is more common. So squamous cell carcinoma in esophagus is more common than adenocarcinoma. Okay. So that is the starting point. Squamous cell carcinoma is seen in the middle third of the esophagus. Adenocarcinoma is seen in the lower third. In stomach, obviously, you get only one type of cancer. Commonly, there are many types, but the common one, of course, in stomach is going to be adenocarcinoma. Right? And in India, or overall, it is most commonly seen in the antrum. Okay. But in Japan and in Western countries, it is in the proximal stomach, like fundus. Anybody can tell why? Why it is more common in the proximal stomach in Japan and in Western countries? Sushi, no. Sushi will act everywhere. It's not sushi. Smoke food, no. Why it is more common in proximal stomach? That's what I'm asking. Whereas in India, it is more common in antrum. Everywhere it is more common in antrum. No, you will realize it. It's not smoke food. So what are the risk factors for both of these cancers? Some are common, like most of you may be following. Smoking. Exam time, you will be smoking. So smoking is same for both. Alcohol for CA esophagus, not so much for CA stomach. Dietary items, and very importantly, sepsis. In esophagus, when I say sepsis, it typically means candida, esophageal candidiasis, which is seen in patients with immunosuppressed states. For stomach, it is the same: smoking, diet, alcohol, not so much. And that doesn't mean start drinking alcohol like you had on New Year, but in diet, smoked foods. And here the sepsis is going to be very important, H. pylori. If there is one thing you need to know about CA stomach, it is H. pylori. Right? It is the most important risk factors undoubtedly. And where does H. pylori sit in the stomach? It is in the antrum. That is why stomach cancer is more common in the antrum. Now in good countries like Japan, there is not so much H. pylori. So there they get cancer anywhere in the stomach. Because H. pylori comes from contaminated food and water. And then you should know some pre-malignant conditions. All of this can feature in your MCQs. Pre-malignant conditions for C. esophagus. Now, it can be squamous cell carcinoma. It can be adenocarcinoma. For squamous cell carcinoma, the important pre-malignant conditions are going to be achalasia. Okay, there are some more, but most important is achalasia. If I have achalasia of the esophagus, it is a predisposing to squamous cell carcinoma. For adenocarcinoma, this will come in your MCQ, is going to be Barrett's esophagus. Okay, Barrett's you will study alag se. So these are the important pre-malignant conditions for esophagus. For stomach, easy pre-malignant conditions. One is Willis adenoma. Where else do you get Willis adenoma? Commonly, you may have studied this somewhere else also. Willis adenoma, where else do you get? Yeah, very good, Deepanshu, good one. For adenocarcinoma, Barrett's esophagus. So Willis adenoma is commonly seen in colon, rectum, right? वहां पर होते हैं. It can also be seen in stomach. So one is Willis adenoma. Then someone earlier wrote pernicious anemia, better known as atrophic gastritis. So atrophic gastritis, hypertrophic gastritis, which has a name you may have studied in pathology. Atrophic, hypertrophic gastritis. also called as Menetrier's disease. ENT wala nahi hai. This is not ENT. ENT was Meniere's disease. This is Menetrier's disease. So these are some pre-malignant conditions. Please understand, nobody will just one fine day get a cancer. You get cancer basically if your esophagus, stomach, whatever GIT is permanently, constantly irritated. Like I will be against you if you keep irritating me, if you keep interrupting me, then I will get irritated. Same way, esophagus, stomach, colon, rectum, if you keep irritating them with any of these things, they will become cancerous. That is the message. So you don't need to mug these kind of facts. They are concepts which will help you. Chronic irritation, cancer. That is a rule. It's the rule in whole of medicine, not just GI onco. Now, how will the cancer look? Okay, the pathology of the cancer. In esophagus, it's very easy to understand. Wherever the cancer occurs in esophagus, it will either look like this. This is called as cauliflower-like or exophytic tumor. Tumor has to look somewhere, right? Or it can be an ulcer. That is called as endophytic tumor. Or it can cause a narrowing of the esophagus, which is called infiltrative, which you may have studied as apple core. So it can be infiltrative or like apple core, napkin ring, the same. The same types of cancers are also seen in stomach, same types, exophytic, or it can be an ulcer, or it can be infiltrative. In stomach, there is one extra type which can involve the whole stomach like this, the entire wall of the stomach. You know what that is called, right? This type 4. That can also be seen. So in stomach, there are two classifications of CA stomach. One is for early gastric cancer, which is called as the Japanese classification. Remember, whenever I say early, early means mucosa, submucosa only. It has not gone to the muscle layer. That's when I call it early, which means it is only involving up to submucosa. Okay, not muscularis. If it is involving the muscularis, it is called as advanced gastric cancer. And this classification that you are seeing for advanced gastric cancer is given by Borman. Right? And advanced means muscle invasive. Right? Muscle invasive is what T stage? Muscle invasive Borman Baba. I hope you have not remembered it like that, Borman Baba. Yeah, excellent, Arav. Muscle invasive means T2, right? So anything worse than T2 is going to be in Borman. Very good. And it has these 4 types, the same types: exophytic, ulcerative, infiltrative. This type 4 is called as diffuse, also called as linitis plastica. Right? This you may have studied in pathology, linitis plastica. All this is simple. Now, why do you need to know cancer can be in any of these types? It's because depending on the type of the cancer, you will get the presentation. If it is an exophytic cancer like this, it will bleed. So person will present with hematomesis if it is an exophytic cancer. If it is an ulcer, person will present with pain. Ulcer's pain. If it is infiltrative, person will present with features of obstruction. Like he may have dysphagia. He will say, Khana atak jata hai, food does not pass. If I eat bread, it gets stuck in my chest. So that is dysphagia. In stomach, if there is such a growth, infiltrative growth, then he will say, I keep vomiting, non-bilious vomiting. So it's very simple. Based on the type of the tumor will be the presentations. But remember one thing, all these presentations are late. These are all bad cancers. Most of the times the patient will come very late. So if he gets these symptoms, it's advanced. Okay? So this is the main message. This is the pathology of the cancer. This, once you understood now, colon, rectum, and other cancers straight SI chale. Okay, this principle you need to understand. Now, all cancers in GIT will spread. They will not sit there nicely. So if you are going to trouble me, obviously I will react. Right? So same way, cancers will also react. Now, how do they react? they are going to spread in three ways. They can spread to adjacent organs, local metastasis. They can spread to lymph nodes, and they can spread in the bloodstream, which is called as hematogens. Esophagus is a very big organ. It is in different parts of the body, right? Some part of the esophagus is in the neck, some part is in the thorax, some part is in the abdomen. Wherever the tumor is, let's say it is here, it will spread to things around it. Like commonly, it can spread to trachea. It can spread to aorta. You know, right? The left bronchus causes indentation. Arc of aorta causes indentation 25 centimeters from incisor. This is a PYQ. Trachopharynx 15 centimeters. This diaphragmatic crura 40 centimeters. Same thing, right? So wherever the tumor is, if it breaches the muscularis, it can spread to the adjacent organs. Same way in stomach, there can be spread to adjacent organs. So from stomach, it can spread to things around it, like it can spread to pancreas. Stomach के पीछे होती है pancreas. It can spread to spleen. This is all direct spread. It can spread to esophagus if it is in the proximal stomach or duodenum. So please understand, cancer is not going to sit there waiting for you to run riot. It will spread to adjacent things. The later you diagnose it, the more it has spread. Apart from this, it can spread to regional lymph nodes. In stomach, the regional lymph nodes have been given some numbers. Like if it is just around the stomach, perigastric lymph nodes, which are counted as D1 group of lymph nodes, those are going to be around the stomach. They are given some numbers 1 to 6. Little further away, along the vessels, the lymph nodes are given some other numbers. जो थोड़े stomach से दूर है, those are going to be numbered 7 to 11. They are counted in D2, which we will discuss in the treatment. So cancer will not only go direct, it will also go into the lymphatics and lymph nodes. Lymph nodes will also be enlarged. And hematogenously, all GI cancers will go to liver most commonly, followed by lung. This is the same for all GI cancers. First liver, then lung. Why do they go to liver and lung? Excellent, Manish, via the portal vein. So from the stomach, it will go into the portal vein branches. From the portal vein, it will go to the liver. So that's how the tumor will spread. Simple. So metastasis happens in this order. Now, how will the person present clinically? Usually when he presents, it's late, but he will present with these features wherever the tumor is. Yahi problem होंगे. So if it's an esophagus cancer, importantly, all of these patients are going to be elderly, not elderly like me, much older than me. They will be elderly, typically more than 60 years old. They will be smokers, usually, and they will be more commonly seen in men. So elderly smoker males, this is the common group which gets these cancers. If it's esophagus cancer, the person will present with dysphagia. And it will increase over time, progressive dysphagia. And what the book says, it starts with more to solids. Initially, it's more to solids than liquids. Baad mein everything will get obstructed. Okay, so history will be 65-year-old smoker male presents with difficulty in swallowing bread, chapati. He'll say, when I eat chapati, it gets stuck. Roti nahi jati hai, roti fas jati hai. Typical history. Over time, he will say, I can't even eat rice. Then he will say, I can't even have a milkshake. Then he will say, I can't even have alcohol. Then he will say, I can't even have water. That's how it will progress. Apart from this, he may have GI bleed, so he may have hematemesis. Okay, he may have late stages, he may have pain, he may have regurgitation. He will say, when I lie down, food comes in my throat. And of course, he may have weight loss. He may have features of metastasis, liver mets, lung mets, so on and so forth, right? So this way the cancer will spread. On the other hand, in stomach cancer, the typical history will be he can have GI bleed, so he can have hematemesis, depending on the type of the tumor. Or he can have non-bilious vomiting. If it is obstructing, he will vomit. So he can have non-bilious vomiting. He can also have pain after meals. That's why many times the patients are treated for peptic ulcer, thinking it is ulcer. Elderly smoker male will not get peptic ulcer. Okay, it's very unlikely. Yeah, because of hematemesis, he can get melena also. No problem. Here also he can get weight loss. And so on and so forth. Or he can have features of metastasis. Any metastatic feature of CA stomach, unique feature, unique to CA stomach, or rather, yeah, Deepanshu, excellent. There are some nice features which are seen in advanced or metastatic CA stomach, like Sister Mary Joseph nodules. Very good, Deepanshu. So you can get Sister Mary Joseph nodules. They are nodules around the umbilicus, paraumbilical nodules. And even more importantly, you can get left supraclavicular node, which is called as Furcow's node. Right, you can get Furcow's node or left supraclavicular lymph node. That is because of metastasis. All this is metastasis, metastasis, metastasis. Now, why do we need to know all this? When patient comes with this, you want to prove he has cancer. So how do you prove he has cancer? What is the first thing you are going to do to prove he has cancer in either of these? You don't know he has esophagus or stomach. Patient nahi bol raha tum. So non-bilious means there is no bile in the vomitus. That means the vomitus is coming from the stomach in gastric outlet obstruction. So how are you going to investigate in both the cases to confirm the diagnosis that it is cancer and where is the cancer? You are going to do upper GI endoscopy with biopsy. So simple. Endoscopy with biopsy. This will tell you if it's esophagus, where is the tumor, upper, middle, lower, squamous cell adenocarcinoma, same way in stomach. So, no, 4 quadrant ya nahi hai. This is not 4 quadrant. Where you see the tumor, you will take the biopsy. So don't imagine. If the tumor is over here, you will take biopsy from the tumor. Okay, ऐसे. So there is no 4 quadrant. 4 quadrant is for ulcers, like Barrett's esophagus. You will do 4 quadrant. So this will tell you it's a cancer. But what do I do next? I want to know metastasis. That is the tumor only in esophagus, only in stomach, or it has spread aspas. So for metastasis, to know whether it is locally spread and whether there is distant spread, for both, whenever I'm writing in common, it is for both. I will do endoscopic ultrasound, EUS. It is a special ultrasound. So I put the endoscope with the ultrasound and it looks at the areas around as the cancer spread around. That is called EUS. Has it gone into the muscularis, serosa, trachea, esophagus? Yeah. And for distant metastasis, PET-CT. Wonderful. Some of you are giving the answer without me asking. Wonderful. Perfect, that is. So this is how I'm going to manage all cancers to begin with. First, I want to know, is it a cancer? Then I want to know, is it a spread cancer? Fourth stage cancer, like how they show in the movies. आपका cancer बहुत फैला हुआ है, आपकी life बची नहीं है. So I want to know, right? In every movie they will tell the stage of the cancer. Same way you as a doctor also should say stage of the cancer. Otherwise, क्या ही doctor हो तुम? If you say no, let's do surgery. Please don't do surgery. Surgeon is telling you don't do surgery till you know the stage. लफड़ा हो जाएगा नहीं. So now I know how much the cancer has spread. This will help me understand the stage or the T and M stage. Because the T and M stage will determine how I'm going to treat it. I need to know the T and M stage. So based on this, I decide is it T1, T2, T3, T4, N1, N2, M1, M0, M1, right? So T and M stage is quite easy. All these GIT organs, they have all the same layers. First they have mucosa, then they have submucosa, then they have muscularis. Then some parts there is serosa, some parts there is no serosa. The tumor is starting from the epithelium, the mucosa. This is adenocarcinoma or squamous cell starting from the epithelium. So in T1A, the tumor is going to be limited to mucosa. That is the first layer. T1B limited to submucosa. That is how the tumor has spread. So this is the early cancer. Then it will go deeper and deeper and deeper and deeper. T2 in all is going to be invading muscularis. Right? T3 in esophagus is going to be adventitious. Esophagus does not have a serosa. And in stomach, T3 is little different. It will be subserosa. Okay, thoda alag hai. So I am just telling you the difference so that it becomes easier to remember. T4A in esophagus means tumor is infiltrating adjacent organs, which can be resected. Organs which can be resected, like it is infiltrating maybe diaphragm, pleura, they can be resected. Esophagus के बाजू में होता है ये सब. And T4B adjacent organs which cannot be resected. Like I told you before, trachea, esophagus, unresectable. Trachea, aorta. Right. So this is how tumor will spread. This is the T stage of esophagus. For stomach, very similar. Only T3 and T4 are a little different. T4A is going to be breach of serosa. And T4B is going to be infiltrating adjacent organs. Now, why I'm telling you like this is because it will be much easier, much easier to study it like this. Okay. Otherwise, you will have a perpetual confusion. You will study one cancer, you will forget the other. Okay, you will study one cancer का TNM says, दूसरा आप भूल जाओगे. So don't do it like that, right? This way, there will be better retention without full rattabazi. How much will you retard? Biochemistry cycles, immunomodulators, उसको कर लो ret. ये तो at least जहाँ easy हो सकता है, where things can become easier, take the easier path. Right? So this is the T stage. N stage you don't need, so don't worry about it. N stage is the same. N1, someone wrote already 1 to 2 nodes. N2 is 3 to 6 nodes. N3 is 7 or more. Lymph node mets. ये वाले, regional वाले. So if there are 1 or 2 lymph nodes here to which the cancer has spread, it will be N1 and so on and so forth. This is the same for stomach also. Okay, so far so good. So far you are getting the gist of it. Now the last part. And once we have done these 2 cancers, other cancers will be the same. So I'm giving little time here. आगे जरूरत नहीं. Yeah, M0 no meds, M1 distant meds. Oppenheimer here, the atom bomb person, is making my life easy. Never thought that would happen. Good one, Oppenheimer. So this way, I come to know the T and M stage. Early stage, stage 4, बहुत देर हो गई, आपको पहले आना चाहिए था. So I come to know this. Based on this, I determine the treatment. All GI cancers, the treatment will be based on stage. Okay, the T and M stage. If it is an early cancer, means T1 cancer, T2 cancer, N1 cancer, it has not spread anywhere much. The mainstay of treatment is going to be surgery. And after surgery, you may give chemotherapy. Okay, you may give chemotherapy. The name of the chemotherapy for esophagus and stomach is called as FLOT. Okay, you can read the full form from the notes. If the tumor is a little spread out, like many lymph nodes, or adventitia is breached, it is going into trachea, then you can't do surgery first, then you will give neoadjuvant chemotherapy. Means first give chemotherapy. Make the tumor smaller so that it becomes operable. Then do surgery. If it is metastatic, afsos, then you are like Zahir from Munna Bhai MBBS. If you have seen it, I don't know how many of you have even seen it. आपके ज़माने की picture नहीं है. So if then you do palliation. Palliation means you will just improve the quality of life, maybe put a stent so that he can eat, or give some palliative chemotherapy, and so on and so forth. Okay, like Zahir from Munna Bhai MBBS. If you have seen it, of course you have seen. I don't think आपके ज़माने की picture नहीं है वो. I don't know how you would have seen it. So whatever you do, depends on the stage. In the MCQ, if they give you there is a person with a CA stomach which has spread to the pancreas, please don't do surgery. Spread to the liver, please don't do surgery. It will either be locally advanced or metastatic. You try to downstage it if you can. So this will be your pattern of treatment. Now for esophagus, what surgery you do is very easy. I will just tell you the concept because this is what can come in the MCQ. So if there is a cancer in the esophagus, the cancer can be maybe in the middle part, the most common side, or the cancer can be in the distal part. Okay, these are the two places where the cancer can occur in esophagus, either proximal part, middle, or distal part. If the cancer is in the middle esophagus, you have to resect esophagus with a 10 centimeter margin. If it's lower down, then proximal margin will be 10 centimeter. Distal margin, which is coming on the stomach, will be 5 centimeters. Okay, because on the stomach side, 5 centimeters. Esophagus side, both ways will be 10 centimeters. So depending on the location, I will do the resection. And what are the surgeries or what are the ways in which I can reach the esophagus? Only two names you need to know. If the tumor is here, lower esophagus, then the surgery that I have to do, see, esophagus is in different parts of the body. Na? Some part is in the abdomen, some part is in the thorax. So for a tumor here, means the tumor inside will be somewhere over here. I will have to take two incisions. One incision will be on the abdomen, one incision will be on the thorax. Double incision. This is called as Ivor Lewis. बस ये नाम समझ लो, Ivor Lewis. This is a double incision. One incision on the stomach, one incision on the chest. Because part of the esophagus is in the chest. If the tumor is here in the middle esophagus, then I have to open abdomen also, chest also, neck also. Because the neck esophagus also has to be removed. पूरा निकालना है ना, तो ये neck तक जाएगा. The upper part may go in the neck. In that case, I have to take 3 incisions. That is called as McKeown's approach or triple approach. In triple, the incisions are going to be on abdomen, right thorax, and left neck. So basically, it is like Ivor Lewis and a left neck incision. So in Ivor Lewis, it is going to be abdomen incision and right chest or right thorax. To Ivor Lewis, if you add a neck incision, it becomes McKeown's. Right? Simple. Don't worry about Oringer. Don't worry about transhiatal. It will only add to confusion. These are the two most important ones, Thara. So ये आपको मालूम होने ही चाहिए. Okay, Ivor Lewis and McKeown's. It's okay if they ask Oringer and you don't know, no problem. But if they ask Ivor Lewis and you don't know it is double, and double means abdomen and right chest, then it's a problem. Then आपको 30 में से 25 marks नहीं आएंगे. और अगर सर्जरी में 25 marks आ गए ना, तो just imagine मेडिसिन में 0 भी आया तो भी कोई प्रॉब्लम नहीं, कॉम्पनसेट हो गया. ऐसा करना नहीं, ओके, ऐसा करना नहीं, but yeah, burden on other subjects reduces. That's what I want it to be. 3-4 big subjects, if you can maximize, other subjects burden will drastically reduce, right? So that is about esophagus and stomach cancers. Very easy now. That was esophagus. Stomach also, I will tell you, stomach to easy to understand. If the cancer is in the stomach, here you don't have different approaches. Here you only have the surgeries, right? इसमें तो सिर्फ surgery. All are from the abdomen. If the tumor is in the distal stomach, which is the common site, you are going to resect at least 5 centimeters proximal, distal till the duodenum. So you will resect this much. Okay, 5 centimeters on the stomach. Here see it is on the duodenum, so you can't go 5 centimeters on the duodenum. This is called as subtotal gastrectomy. And if the tumor is higher up, more proximal, जो जापान में होता है, इंडिया में नहीं होता. If it is somewhere over here, then you will remove full stomach at least 5 centimeters proximally and at least 5 centimeters distally, if not more. Practically the whole stomach, almost पूरा stomach आ जाता है इसमें. This is called as total gastrectomy. Only 2 surgeries based on location. So simple, right? So these are going to be the surgeries, and then they will ask you how many lymph nodes you remove. Normally, what you do is a D2 lymphadenectomy, in which you remove the perigastric nodes. Okay, perigastric will be removed, means number 1 to 6, and you will remove the bigger nodes along the vessels. Okay, please be very clear about this. When I say D2, it means 1 to 6 and 7 to 11. Please don't say D2 is 7 to 11. Huh? You cannot reach the nodes away till you don't remove the nodes around. Okay, like I cannot teach you treatment of cancer till I tell you what the cancer is. I cannot straight away say, oh, CS stomach treatment is gastrectomy till I tell you stomach cancer is a adenocarcinoma in proximal stomach or distal stomach. So वैसे होगा ना. Same way, D2 is not. You may have learned it wherever, I don't know, that D2 is 7 to 11, but that's wrong. Okay, it's common sense. First, you will remove the nodes around the stomach, then you will remove the nodes a little away. Okay, so these are the surgeries for stomach. इतने जानने easy. ये दो कैंसर हो गए ना, the other cancers will follow the same sequence, no problem. एकदम बैठ जाएगा दिमाग में. Yes. So that was about the cancers. This came, someone was asking, are you going to teach? So this was a PYQ. What is the classification for advanced CS stomach? Yeah, it is Borman. What is Lauren? Lauren is for the pathological types or the microscopy of CS stomach. Intestinal type, diffuse type, that is Lauren. Intestinal type, diffuse type, CS stomach, that was Lauren. Japanese, I told you, was for early gastric cancer. Mucosa, submucosa. What is Duke's? Duke's classification? Yeah, excellent. Old classification of colorectal cancers. It is different from TNM. It's an old classification. You had Duke's 1, Duke's 2, Duke's 3. Okay, Duke's 1, tumor limited to mucosa and submucosa. Duke's 2, muscle or more. And Duke's 3, lymph node metastasis. Okay, this was for colorectal cancer. When they didn't have TNM, they would use this. Okay, so this was PYQ. Same way, colorectal cancer. It will take maybe 10 minutes to understand colorectal cancer. They are very similar. जैसे हमने ये cancer किए ना, same way you will do colon and rectum, and you will realize in maybe 45 minutes we have done the 4 most difficult cancers in the whole of general surgery. 4 cancer ऐसे हो जाएंगे. Another. Again, they are also bad cancers. Why bad? Because they come very late. Same way, person will get symptoms which you will see, which will be seen in so many other diseases. Some of you may be having those symptoms and you will be like, do I have a colorectal cancer? Right? So they are bad cancers. Both of them are going to be adenocarcinomas, like stomach only. This is also going to be adenocarcinoma. Now, who gets the cancer? The risk factors are the same. Of course, the most important, many of you will be having smoking. The second one, which you may be having more, spirits. And the third one is going to be sepsis. अभी यहाँ पे H. pylori नहीं है, Candida नहीं है. Your sepsis means change in gut bacteria. If the gut bacteria change. And the fourth is diet. Some dietary risk factors, constipation, a lot of red meat. जो आप लोग रशिया, यूक्रेन, जहाँ भी हो वहाँ पर बहुत खाते होंगे. So constipation, less fiber, in having a lot of red meat. All these are bad. Yeah, for cancer, you can eat if you want, but risk of colorectal cancer will increase. And then you have pre-malignant conditions. One I already taught you is the Willis adenoma. most important one, adenomas. They can be seen in some syndromes also, villus adenomas. Like there is a syndrome, FAP syndrome, HNPCC syndrome. Those are seen in syndromes. And the other one, a very important risk factor, is ulcerative colitis. Okay, ulcerative colitis. Which part of the colon does ulcerative colitis affect commonly? Which part commonly gets affected in ulcerative colitis? RRRRR. Yes. I don't know why you put it like that, but I hope it's not from some mnemonic. Ulcerative colitis actually should be called as ulcerative proctocolitis. Procto means rectum. This disease starts in the rectum. Okay, you can never have ulcerative colitis which starts in the colon. It will always start in rectum. And it may inflame the rest of the colon proximally in a continuous manner. So it spreads proximally in a continuous manner. Crohn's disease typically affects terminal ileum. It can affect some part of colon. It can affect perineal area. That is Crohn's disease. Crohn's में cancer इतना common नहीं है. Cancer is common in ulcerative colitis. Which is the most common site of cancer in ulcerative colitis? Most common site of cancer? Rectum. Because it starts in the rectum. Rectum will be most irritated. Which is the most common site of colorectal cancer? Between colon and rectum, the whole tree. Which is the most common site of colorectal cancer? Descending colon, cecum, rectosigmoid. Answer is rectum. Okay, rectum is the most common site of colorectal cancer also. Anybody can tell why? Why rectum? If you know why, you will never have a doubt in your life. Because understand, all your stools and all the toxins in the stools will sit in the rectum. When you go to the toilet and you pass motions, what you are passing is rectum, contents of the rectum, not colon. So all your stools are stored there. So all the irritation will be in rectum. Simple. Okay. So no rocket science. This is the fact. This is the concept. That's why rectal cancers are more common than any other part of colon. Now come to pathology. Again, the cancer can present based on the location. And this they will ask you in FMG. They may have taught you in pathology also. I don't know. So when they talk about these cancers, same way. The most common site is going to be rectum. Okay. How much? 38%. Second most common site, of course, will be sigmoid colon. Little more storage there. If not rectum, then sigmoid. That is the second most common site. 21%. Now, what they say is cancers in the ascending and cecal, this part, are more exophytic. Typically, because the stools are not yet formed, so these are more exophytic cancers. Whereas descending colon cancers are more like this, constricting type. Because your stools are formed, so tumor cannot grow in the lumen. So here the tumors are going to be more constricting. Okay, so just like esophagus and stomach, you can have exophytic tumors, you can have constricting tumors. So if the tumor is exophytic, means like a cauliflower, this is the tumor which will bleed. So right-sided colon cancers present with bleeding in stools. A constricting tumor will present with narrowing, so person will present with constipation or change in bowel habits. आई बात समझ में? So that is the message I want you to have. This is the fundamental. You can predict where the tumor is based on the presentation. Okay, rectum will behave a little differently, which you will do in the clinical features. This is the pathology, the gross types. Microscopically, all are going to be adenocarcinomas. They can also spread everywhere. So the spread again here also will be in adjacent organs. So whatever is in the vicinity, it can spread to. Or it can have lymph node mets, it can have hematogenous mets. So adjacent spread, lymph node mets, hematogenous mets. Hematogenously same, it will go commonly to liver, followed by lung. Okay, we are talking about both colon and rectum. Simple. Then you come to clinical features. Again, clinical features, if it is a colonic cancer, I already told you, he will be elderly smoker male. So elderly smoker male is your risk group for all your GI cancers. Elderly smoker male, he will either have PR bleed or he will have change in bowel habits. If someone like you gets PR bleed, what will you think? Someone like you, 25-year-old, gets a PR bleed. Polyp? No, not you will not have polyps. Hemorrhoids is not PR bleed. Hemorrhoids is bleeding during defecation. It's not blood in stools. It is blood which drops during passing stools. If someone like you, young patient, gets PR bleed, you will not think of colorectal cancer. You will think of ulcerative colitis. You will have ulcers in the rectum, ulcers in the colon that cause bleeding. So young patient, young non-smoker male like you, ulcerative colitis. Elderly smoker male, not like me, with PR bleed, think about colorectal cancer. That's the message. Okay. So young patients, ulcerative colitis, old patients, colorectal cancer. If it's a rectal cancer, then the first symptom usually is going to be PR bleed, but they get some unique symptoms. They get some other features like spurious diarrhea, early morning, spurious diarrhea. He will say that I pass a lot of liquid motions. That is called spurious diarrhea. And he gets tenesmus. Tenesmus is a desire to pass stools. So he will say, I keep feeling like I have to pass motions. That is tenesmus. The same things can be seen in ulcerative colitis in a young patient. Same things. So these are going to be the clinical features. Then you are going to investigate. How will you investigate? What will you do first when you are investigating colorectal cancer? So first you want to confirm it's a cancer. And to confirm, you will do endoscopy, colonoscopy with biopsy. Same for both. It will show it is adenocarcinoma. Then I want to look for metastasis. Early stage, advanced stage, metastatic, Zahir, right? So here it's a little different. If it's a CA colon, then for local stage, I'm talking about local staging. Means aspas. For colon, I do CCT abdomen. I don't do EUS. EUS you can do, not preferred, because see, colon is very big. If the cancer is in the cecum, your EUS may not reach till there. CT will see the whole colon. But if it is rectum, this is the one I want you to remember. This is the place where you will get stuck. If it is a rectum, then you will not do EUS, you will do MRI of rectum. So the message is any tumor in the pelvis, rectum, bladder, prostate in men, and uterus and cervix in women, all these rectal cancers, pelvic cancers, you do MRI. MRI is better than EUS for these kind of cancers. Okay, so EUS is for esophagus, stomach. Here you will prefer in these cases to do CT or MRI for local spread, and for distant spread it is the same. For distant you do PET scan. For both are easy. So now you come to know the T and M stage. Okay, which will look like this. Oops. The T and M stage. Now the T and M stage, now I'll put it in a very simple way. The T stage of CA colon is same. It's the same for both. It is same as stomach. Okay, so you don't need to worry. जो स्टमक का है वही कोलॉन का है, वही रेक्टम का है. So T1 AB mucosa submucosa, T2 muscularis, T3 subserosa, T4 serosa, T4B adjacent organs. It's the same as stomach. So easy. End stage, forget about it. Don't need end stage. Okay, end stage you don't need. So you got the T and M stage. Now you are going to decide the treatment. Same way, early, advanced, metastatic. If it's early, you will do surgery followed by chemotherapy. Okay, the chemotherapy that you give here is called as FOLFIRINOX. Just remember this name, FOLFIRINOX. You can see the full form if you want from the notes. FOLFIRINOX. If it is advanced, same way, you will do chemotherapy, then surgery. And if it is metastatic, you will do palliation, like a stent or something. So treatment of all GI cancers goes in the same pathway. If it's early enough, jaldi pakad liya, surgery, chemotherapy. If it's big, can't do surgery, first make it small by giving chemotherapy and then do surgery. And one point over here, one extra point. If it's a CA rectum, only for CA rectum, and if it is advanced, you are going to give neoadjuvant, not chemotherapy. You can give radiotherapy also. You will give neoadjuvant, chemotherapy, and radiotherapy both. Okay, so only for rectum, not for colon, and not for stomach, not for esophagus. Agar tumor advanced hai, you can give radiotherapy also. Yeah, liver mets are resectable, but let's not make it so complicated. Liver mets are, even lung mets are resectable if they are 1 or 2 mets, but let's not overcomplicate it. They will not give you a tumor with mets. If they give you with mets, assume it to be palliation. Keep it simple. They should not, because it's little too many factors. So only for CA rectum, neoadjuvant radiotherapy is also included, which we didn't do for any other cancer. Now the last part is going to be what surgeries do you do? So surgeries, like how did we decide for esophagus and stomach? Same way you decide for colon and rectum. Middle esophagus, lower esophagus, distal stomach, proximal stomach. Same way you decide for colon and rectum. Principally, it is the same. For colon, depending on the location, if the tumor is in the right side, like if the tumor is located in the cecum or ascending colon, this side, you will resect the cancer like this. This is called as radical right hemicolectomy. Okay, this is called as radical right hemicolectomy. This tumor. If the tumor is little higher up, let's say it is over here, you will resect a little more till here. So if it's little higher up on the transverse colon, so tumor is in the transverse colon, proximal part, you need to do little more than this. So like you had Ivor Lewis and then you had McKeown, here you will do extended right hemicolectomy. Okay, simple. And if the tumor is on the left side, sigmoid colon. So if it is in the descending colon or sigmoid colon, then you are going to do radical left hemicolectomy. Okay, बस इतना ही है. So just like esophagus and stomach, what part is going to be removed is going to depend on the location. And the next thing here is there is no margin. If you want to talk about margin, in all of these, the margin should be more than 5 centimeters. Like stomach, more than 5 centimeters. But let me tell you, this is not what is practiced. What is practiced are these resections. They are predefined resections. कि अगर यहाँ पर tumor है, I will resect all of this. If the tumor is here, I will resect all of this, and so on and so forth. So the resections are predefined based on the blood supply. So you have right hemicolectomy, extended right, and left hemicolectomy for cancer of the colon. If the cancer is in the rectum, again it's the same. The treatment depends on the location. So this is the sigmoid colon, and this is the rectum, and this is the anal canal over here. if the tumor is in the upper part of the rectum, over here. So same way, you see the whole oncosurgery goes in the same system. It becomes so easy if you understand it like this. If the tumor is in the rectum and if it is in the upper rectum, then what I do is I will resect. I go 5 centimeters proximal and distally I go about 2 centimeters. Rectum's distal margin is only 2 centimeters. This is called as, I resect all this and I do joining. This is called as anterior resection of rectum. In the books, you will hear the word or read the word AR, anterior resection. So for upper rectal tumors, anterior resection, resect it and join it. If the tumor is lower down, very close to the anus, very close to the sphincters, in that case, you don't do resection and anastomosis. So if the tumor is in the lower rectum, where the sphincter will get damaged if I go 2 centimeters below, in that case, I do what is called as abdominoperineal resection. Okay, abdominoperineal resection for lower tumors which will be very close to the anorectal sphincter. That is called as AP. Okay, and whenever I do APR, I don't do joining. I resect, but I don't join. I do a stoma, a colostomy. Okay, so you need to know in the whole of rectum only these two surgeries. Upper rectal tumors, resection anastomosis. Lower rectal tumors can't do resection anastomosis, so you resect and do a proximal stoma. You need to remember the names of the vessels. Arindam, I don't think they should ask you. Realistically, they should not. Yeah, realistically, they should not. Maybe when you prepare for NEET PG, that time you read all that. So in lower rectal tumors, I resect all of this. इतना सब मैं resect करूँगा. But see, it is very close to the sphincter. So sphincter is also gone. If sphincter is gone, I don't do any anastomosis. This part, the proximal colon, whatever is left, we have resected it, na? This much is left. This I bring out as a stoma, colostomy. So I resect rectum, anal canal, and then whatever colon is left, I bring it out as a stoma. So he does not have any anal opening. Whatever stools will form will come out into a bag on the abdominal wall. That is called a colostomy. Yeah. Circular stapler can be used only if the tumor is away from the anorectal ring. If it is near the anorectal ring, nothing will work. Okay, so if the sphincter is going to go, then even circular stapler will go through the sphincter. Keep it like this. It is simpler to understand it like this. Otherwise, it will be very complicated and you will make a mess of it. जोर नहीं लगाना पड़ेगा फिर स्टोमा अपने आप चलता है जोर इनफैक्ट यू विल जोर लगा के ट्राई टू स्टॉप इट इट्स द ऑपोजिट बिकॉज देयर इज नो स्फिंक्टर देयर सो सब अपने आप ही आएगा बाहर जोर लगा के उल्टा हो गया ये तो हम चाहे तो भी ये नहीं रुकेगा यस एब्सोल्युटली राइट okay this was asked in FMGE Jan we kind of discussed this before while doing an endoscopy if a constriction is noted at 25 centimeters from incisors what is the reason for it yeah so it is arc of aorta if this is not there in the option it is the left main bronchus okay left main bronchus so aorta left atrium left main bronchus not right bronchus cricopharynx is going to be at 15 centimeters arc of aorta is going to be 25 centimeters from upper incisors and diaphragmatic pinch will be at 40 centimeters okay 15 plus 25 equal to 40 all measured from upper incisors okay all of this is measured from upper incisors right so that was this question so these are the cancers If both in option they will not give, then left bronchus, not upper lower bronchus. Go for left main bronchus if it is there. Otherwise, arc of aorta or left atrium. Both options won't be there. The confusing options will be right bronchus. Okay, so that was about the cancers. All cancers done for GIT, no problem. Any question on any cancer, you should be ready. Whether it is anatomy, whether it is microbiology, whether it is pathology. If left was there, they would have given left and some branch, like they would have said left lower bronchus. For example, left lower. Then obviously that is not the answer. Okay, it should be left main bronchus, not left upper or lower. So arc of aorta and left upper or lower, go for arc of aorta. Okay. Now, so those were the cancers. Now some important benign disorders, and then acute abdomen is what we are going to do. Now, what is achalasia? Achalasia typically means failure to relax. Like how many of you don't relax? You are like achelastic. So you need to relax. So there will be a failure of relaxation. But what is going to fail to relax? There will be failure of relaxation of lower esophageal sphincter, LES. But that is just one half of the problem. So what is going to happen is the sphincter here, LES, does not open. But at the same time, even the peristalsis of the esophagus has become very weak. So the second problem, both of these have to be there to be calling as achalasia. There should be ineffective esophageal peristalsis. Okay, both of these have to be there to call it as achalasia. There should be ineffective esophageal peristalsis. Both of them have to be there. And why does this happen? This happens because the ganglia are absent or the ganglia are reduced. So not NOVIP, but NOVIP affecting what? It is because of absence of parasympathetic ganglia or absence of vagal branches. There is absence of parasympathetic ganglia. Where do these ganglia occur, or where are they going to be seen? In the muscles, myenteric plexus. All right. The neuromodulators are nitric oxide. Okay. So this is the most common esophageal motility disorder. Most common esophageal motility disorder overall. There are others also. This is the most common one. How does it present clinically? So if there is weak peristalsis and if the LES does not open, how will the person present? Typically, he will be a middle-aged patient. मेरे से भी थोड़ा बड़ा होगा. मेरे जितना चलो middle-aged, you can count me as middle-aged, but he will present with dysphagia. But he is not going to be an elderly smoker male. He will typically be middle-aged, usually females, middle-aged females, typically. He will present with dysphagia, and the dysphagia is initially more to liquids, ulta. But they will not give this in the exam. In the exam, they will not say it is more to liquids because they know you know this buzzword. So they will not put this. So you will have dysphagia. He will have regurgitation of foods. He will say when I lie down, food comes up, and he will have weight loss. Khana ja nahi raha, so weight loss hoga. These three together are called as triad of achalasia. Okay, these three together is called as triad of achalasia. If with this he also has heartburn, means burning in the chest, then these four symptoms together are used in a score which is called Eckhart score. Okay, so X score, if you can remember the name, fine. These four symptoms are counted in Eckhart score. Is there any other place where you got the same symptoms? Dysphagia, regurgitation, weight loss. कहीं और भी थे ये symptoms? No, not GRD. GRD में नहीं थे. In C esophagus. ये भी किया ना C esophagus. They had the same symptoms. Dysphagia, hematemesis, regurgitation, weight loss, more to solids. So very similar symptoms. You also get in CA esophagus, which is why middle-aged female, achalasia. Elderly smoker male, cancer. That is the message. And the second thing is symptoms of achalasia in cancer is called as pseudo achalasia. So elderly smoker male can present with pseudo achalasia, right? So progressive is cancer, वो देंगे नहीं. Yash Bala, you are right, but they will not give that in the presentation because they know you are very smart. Yeah, they know you are very smart. And yeah, it is a pre-malignant condition. So patient comes with these symptoms. What is the first investigation? Yeah, you are right. This is pre-malignant for squamous cell carcinoma. That is a risk factor for squamous cell carcinoma. What is the first investigation? Please don't say barium. Barium is not really the first investigation anymore. First investigation, if this is there in the option, you go for endoscope. Okay. If it is not there in the option, only then go for barium swallow. But realistically, they will not give both. If endoscopy is there, go for endoscopy. Why am I doing endoscopy? I want to rule out cancer. Okay. I want to rule out cancer. And the investigation of choice is this nice looking thing. This is the investigation of choice. It is called as esophageal manometry. Okay, it is called as esophageal manometry. Manometry means pressure measurement. So it is measuring the pressures in the esophagus. It is given by this classification, Chicago. Now, when will you say it is achalasia on Chicago also? These two things have to be there. Failure of relaxation and ineffective peristalsis. That is called as classical achalasia. Both these main findings are there. That there is increased LES pressure, number one, and there will be ineffective peristalsis. Only then I will say it is achalasia. That is your classical achalasia. In type 2 achalasia, there will be something called as pan-esophageal pressurization. अगर ये याद रख सकते तो ठीक है. If you can't remember this, it's okay. They asked this in a NEET PG. Pan-esophageal pressurization in more than 20% swallows. And in type 3, you will see spasms of the esophagus in more than 20% of the swallows. Okay, if you can remember the types, fine. If you can't remember the types, let it be. Okay, don't worry about it. Yeah, someone remembers the types. Oppenheimer, yeah, Chicago classification. So, achalasia you can diagnose on manometry very easily, there is no doubt. What do you do next? You have to treat. Do you have to treat every achalasia? They give you this history geography. Our patient को treat करना है क्या? That is one. And second thing is, in olden days, they used to diagnose using a test, which I told you is not to be done anymore realistically. And that was this test. This is called barium swallow. In the era of endoscopy and in the era of manometry, barium has very little role. If you don't have manometry, you do barium. Yeah, Arpita, excellent. So in barium, you will see this dilated esophagus and you will see this narrowing. And this narrowing is a gradual narrowing or a smooth narrowing. Okay, which you can call as bird beak if you want. Beak of a bird, imaginary bird beaks. On the other hand, in this case, you are seeing the narrowing, which is happening very suddenly. So suddenly it broad and then it becomes narrow. That is called as shouldering. And this shouldering or sudden narrowing with a big filling defect, this is going to be seen in C esophagus. Right? Bird beak, smooth tapering is going to be seen in achalasia. Used to be done earlier. Today it is done in places where you don't have endoscopy. अगर endoscopy नहीं है तो ये कर सकते हैं. Now, does every patient need to be treated? Answer is yes. All patients have to be treated. All have to be treated because it is pre-malignant. All right, it is a pre-malignant condition. So you can't say you have achalasia, sit happily when you have problems, that time come. Let's not do that. And you can do medical management, you can do endoscopy, but the treatment of choice is this surgery, which was a PYQ. It is called as Heller's cardiomyotomy. Right, this is Heller's cardiomyotomy. Myotomy means cutting the muscle. So you do surgery, you cut the muscle of the lower esophagus. So how much do you cut in the lower esophagus? You do the myotomy in the lower esophagus for about 6 to 7 centimeters. This much lower esophagus is cut. Mucosa is not cut. Otherwise, you will say, sir, esophagus cut there is a perforation. You don't cut the mucosa. Mucosa is left. Muscle is cut. Myotomy. And in the upper stomach also you do a myotomy. So in the cardia of the stomach, you will do myotomy of just about 2 to 2.5 centimeters. What problem do I get if I do this myotomy? Yeah, if I have cut the muscles, if I have cut the LES, he can get reflux. So the problem of achalasia, after doing Heller's myotomy, he can get GERD. To prevent GERD, I add a anti-reflux surgery like a door fundoplication. So to prevent GERD, at the same time, I will also add a door fundoplication. What is door fundoplication? How much do I plicate in door fundoplication? It is a 180 degrees anterior. Easy to remember, this muscle that I have cut is anterior. So the stomach, I bring it over here to cover the myotomy. So it will be anterior 180 degrees. पीछे लेके जाने की जरूरत नहीं है. So it is an anterior 180 degrees fundoplication. This is the one which is done with Heller's myotomy. Okay. In Nissen Tupe, those were for GERD only. When the person has GERD, I do Nissen or Tupe. If he doesn't have GERD, for prevention, this is good enough. काम हो जाएगा. Okay, and there is a new treatment which is called as POEM procedure. POEM also called as per-oral endoscopic myotomy. It's a type of those notes procedures, natural orifice surgery. So it is done by the endoscopy route. Per-oral endoscopic myotomy, also called as POEM. So these are the two surgeries as of today which are being done. If they ask you surgery of choice, go for Heller's cardiomyotomy. But this endoscopic POEM, again, very important. Okay. Do we do it in all cases? So, except in very early cases, you will do the surgery only. But if it is very early, why will the patient present? If he has very little dysphagia, right? Then why would you even do it? Okay. So, that is about achalasia. Another important disease, which I'm telling you will come in your exam, is Barrett's esophagus. Very important, Barrett's esophagus. Barrett's esophagus, the first thing you need to know is it is a complication. It does not happen by itself. It's a complication of GERD. Like some of you are complicating bringing GERD into my life. So if you keep writing nonsense comments like some of you are writing, then obviously the esophagus will get irritated and it will become metaplastic. So normal lower esophagus is squamous epithelium. If because of acid, it undergoes a squamous to columnar metaplasia. So it is a columnar, means the squamous epithelium has become columnar, intestinal. It is a columnar metaplasia of lower esophagus. And in whom does it occur? It occurs obviously after GERD. And this columnar metaplasia will show mucus secreting goblet cells. That's how you know it is a metaplastic epithelium. It will show mucus secreting goblet cells. Now, what is the problem if I have Barrett's esophagus? This Barrett's epithelium, it has undergone metaplasia. It is also pre-malignant. So there is a risk of cancer, right? So there is a risk of cancer. If it is only metaplasia, the risk of cancer is very less. It is 0.2 to 0.5% annually. if the metaplasia has become dysplastic. Okay, if it is dysplastic is a dangerous word. Dysplasia means khatra. Then the risk of cancer is 0.7% annually. And if the dysplasia becomes high grade, aggressive dysplasia, like some of you tend to become in class, then it is going to be 7%. Whenever you see the word dysplasia, please understand dysplasia cannot be ignored. You have to do something for it. Metaplasia can calm down. Okay, like some of you calm down, but many of you don't. If you become dysplastic, I have to chuck you out. Same way over here. Whenever you see dysplasia in class, it has to be removed. Only metaplasia, making harmless comments, fine, no problem. Then I will shout at you, you will become quiet. But if you continue, that means आपके दिमाग में कुछ problem है, सटक गई है. Maybe you are not giving FMGE exam now. Maybe you are ready to give it later, right? So in that case, I have to take action. Dysplasia, take action. Okay. Deep Prakash are all relating to it. They would have faced it in the earlier classes also, I am sure. Right? So, whenever there is Barrett's, the person clinically will have features of GERD because it's a complication of GERD. So, GERD ke investigation, I will come to know there is Barrett's, and someone very correctly wrote the first step that I am going to do is going to be endoscopy. What does this image show? First step is going to be apogee endoscopy. What do you see in the first image? Don't see the second image. Second image you've already seen in your life. What do you see in the first image? First image. You are seeing salmon. You are imagining red velvety mucosa. Let's not imagine things. Erosion. No. This is the stomach. The red part. You see these folds. They are your gastric rugosities. This pale part is the esophagus. And what do you see here? This circular thing. This is your normal. This is normal GE junction or normal Z line. So normal gastroesophageal junction, which is also called as Z line. ऐसे दिखती है Z line. Okay. Now see this GE junction. Here you can see these projections. So on endoscopy, you are going to see pink, salmon, tongue-like projections. I don't know how many of you have eaten salmon. It is a tongue-like projections. And these projections, if I take a biopsy, it will show columnar epithelium on biopsy, which tells me it is Barrett's columnar metaplasia. There may also be dysplasia. Now, what they say is, don't just take one biopsy. Take multiple biopsies. Yeah, not Seattle protocol to diagnose, Seattle protocol for prognosis, for both. Every time I do endoscopy, I don't take one biopsy from here. I take 4 biopsies, circumferential, 4-quadrant biopsies. And I don't take it at one level, I take it at 2 centimeters gaps. That is called as Seattle diagnostic protocol. Okay, that is called Seattle diagnostic protocol. Triangle means diagnosis. Huh? So I take 4-quadrant biopsies at 2 centimeter intervals. Because it's possible, I take biopsy from here, I see no dysplasia. But I take biopsy from here, there is dysplasia. That means dysplasia is there. Na? Now there are 200 plus of you in Zoom. I don't know how many on YouTube. So I cannot pick out randomly okay, who's nasty, who's metaplastic, who's dysplastic. If I start questioning you individually, tab pata chalega, oh, Shuk Patel is a good boy, but oh, someone else is not. So that way, एक आदमी का example नहीं ले सकता हूँ to label as someone having dysplasia or not. I have to check it at multiple levels. That is the Seattle diagnostic protocol. That every time you do endoscopic biopsy, multiple sites. Investigation of choice biopsy, endoscopic biopsy. Right. So this will tell you whether it is only metaplasia, low grade or high grade dysplasia. And the treatment will depend on that. If it is only metaplasia, you are good boys, most of you, nothing needs to be done. In that case, just treat the GERD. But obviously, you have to do endoscopic surveillance. So I have to be watchful. Now I have to keep your names in memory so that in the latter part of the class, if you start acting smart, I have to catch you. So I do endoscopic surveillance. This will be done. It's given very differently in many places. On an average, you take 3 years. Okay, 3 years per picture. If there is low-grade dysplasia means you have to be removed. So I will do endoscopic resection. And of course, after that, I will treat the GRD. कि भैया आप लोग ऐसे क्यों behave कर रहे? And if there is high-grade dysplasia is dangerous. You have to be removed. So I treat you like a cancer. I do esophageal. Right. So this is going to be my management. This is the most important part of Barrett's, the risk of cancer and the treatment. और कुछ नहीं पूछेंगे, ये पूछेंगे अगर पूछेंगे. If they ask you the what it means, it's very easy. You know what it means, but they will ask you about the treatment. This is the treatment. Right? Okay, answer this. FMG Jan 2021. So patient has progressive difficulty in swallowing both solids and liquids for 8 months. And this is the image. See, progressive is the word they have given. Why are you writing achalasia? Image is enough. Many times the image will be very poor. Okay. Many times the image will be very poor. So don't say image is enough. What if you can't make out from the image? Here you can, because I am a gentle person. I have given you a nice, smooth tapering wali image here. But what if the image was little hard to understand? Please then see the age. Okay, 30-year-old achalasia. You don't expect carcinoma esophagus. Okay, corkscrew esophagus is seen in what condition? अब ये क्वेश्चन ओल्ड हो गया. I hope ये क्वेश्चन ना आए. Yeah, it is seen in diffuse esophageal spasm. DES. Very good. आपको PYQ चाहिए थे इसलिए मैंने डाला यार, वरना मैं क्यों डालता? You said ना सर PYQ पढ़ाएंगे ना, इसीलिए. So for GERD, the best investigation is 24-hour PS study. For GERD, you do those fundoplications. Someone was asking, na listen, kisme karte? So fundoplications are done for GERD or for hiatus hernia. That's where you do listen, toupee. Those are done for GERD, not for achalasia. For achalasia, it is cardiomyopathy. So that was about esophageal benign disorders. Now very easy disorder, infantile pyloric stenosis. I have taught this before many times. I'll put it in a very simple way. The key word in infantile pyloric stenosis is infantile. Okay, focus on this word, infantile, because it will not present in neonates. It will present when the child is little older, between 4 to 8 weeks. Means baby is born, mother is discharged after 1 or 2 days. Mother starts feeding the baby. First few weeks he is fine, and after a month or so he starts vomiting. That is infantile pyloric stenosis. In pyloric stenosis, the question old नहीं हुआ, this pyloric sphincter has become thicker, so this gets obstructed. So there is a hypertrophy. The child presents with pyloric obstruction or gastric outlet obstruction. This will typically come at this period, 4 to 8 weeks. So what will the mother say? Whenever she feeds the child, after some time, the child has a non-bilious vomiting. Obviously, bile cannot come there, so it will be a non-bilious vomiting. And when she examines, or when the pediatrician will examine the child, he will say that whenever you feed, you can see peristalsis. And the peristalsis is going from left side to right side, left to right. It will go in this direction. So you can see the peristalsis of the stomach on the abdomen. This is one point. And second point is, many times the neonatologist or the pediatrician can palpate the pylorus over here. This pylorus is palpable. But for that, the child should be quiet. When the child is quiet, he's not crying, he's not vomiting, you can palpate it. Palpate the pylorus. Someone correctly wrote, it will be felt like an olive mass. Right? It will be felt like an olive mass. So it is palpable. But the child should be quiet. He should not be vomiting. He should not be crying. When this happens, what will the neonatologist or pediatrician do? First thing is he will ask for some blood tests to see how much has the child been vomiting. What will you see in the blood test? Very important. You will see low potassium, hypokalemia. You will see low chloride, hypochloremia. Everything hypo, but metabolic alkalosis. Right? Metabolic alkalosis. Your urine will show acid urea. I'm sure you know why all this happens. Everything is lost. Potassium is lost. HCl is lost. Acid is lost. If acid is lost, it will become alkalotic. HCl is acid. You get acid urea, but you will get metabolic alkalosis. Low sodium is usually corrected. Low sodium nahi hota. Sodium gets corrected. Your renin angiotensin system will absorb the sodium, so at least sodium will be retained till it's very advanced. To confirm the diagnosis, there is only one thing you need to do. That is going to be USG of the abdomen, right? In which you will see thick pylorus. The pylorus will be very thick. It will be more than 4 millimeters. Length will also be increased. This hypertrophy is more of the circular muscles. Circular ज़्यादा hypertrophy होते. This was also PYQ. And the last part is treatment. So treatment, usually you have to do surgery because it's a very thick pylorus. You have to cut the muscle. This is called as Ramsted's pyloromyotomy. Right? Ramsted's pyloromyotomy. Please have a good look at this image. They can put this image. This is the stomach. This is the pylorus of the stomach, which they are cutting. What is this over here? This brown thing behind the stomach. वो क्या है? This brown thing behind the stomach, this is the liver. Okay, ऐसे दिखती है liver. And what is this yellow thing going from the liver? What is that? That yellow thing suspending the liver. Yeah, that is the falciform ligament. No, not common hepatic duct. That is falciform ligament. ऐसे दिखती है falciform. If you have never seen it in your life, it looks like this. This yellow thing. It goes, suspends the liver to the abdomen, anterior abdominal wall. And this little thing over here probably is the gallbladder. Duodenum के पीछे होता है gallbladder. Probably it's a gallbladder, as I can see it. So get some orientation to these kind of things. So there is infantile pyloric stenosis. Yeah, you got this one. I hope you did. Complication, presentation is gastric outlet obstruction. It's not a complication, it's the presentation. So you can put it the same way. Presents with non-bilious vomiting. See, really speaking, nothing is 100% sensitive. Nothing is 100%. But yeah, it's not due to hypertrophy or longitudinal. It's more of circular muscles. Longitudinal भी होते हैं, but circular ज़्यादा होते हैं. That's why it will cause a constriction. Circular will constrict. Right? And hypokalemic alkalosis, what is same. Now come to one more important, not such a difficult disease, that is peptic ulcer. Some of you may be having it. Serosa and muscle, yeah, serosa and muscle. Only mucosa is left when I do myotomy. Only mucosa is left. Yeah. So peptic ulcer is actually not because of peptic or pepsin. Pepsin is what you need for protein digestion. It is because of acid. Right? It is ulcers due to acid. Typically, these ulcers will be seen in the stomach, or they will be seen in the first part of duodenum. These are the common sites of this acidity-induced ulcers. आपको होते होंगे ना अभी आप एग्जाम टाइम इतना सिगरेट पियोगे. You will get it. Heartburn is in esophagitis. Stomach is not in the chest. So heartburn is not the main symptom. It can be there, not the main symptom. Who gets these ulcers? The main thing you need to know is gastric ulcers are not because of acid per se. They are because the mucus barrier is lost. Okay, your stomach has a coating that is called mucus barrier. If that is lost, you get gastric ulcers. Duodenum has nothing to do with any barrier. Duodenal ulcers will occur because of extra acid. If there is too much acid, you get duodenal ulcers. Mucus barrier lost, you get gastric ulcers. So gastric ulcers typically are going to be seen, this barrier is going to be lost in people who take NSAID. Prostaglandin will fall in NSAID. Yeah, hurry, worry, curry in Robin's gone, not anymore. Of course, everything is associated with smoking. And very important, H. pylori. H. pylori can cause CS stomach, H. pylori can cause peptic ulcer. Duodenal ulcers again can be linked to smoking and H. pylori. So the main message is stomach disease, H. pylori should be looked for. Because H. pylori, as I already told you, can cause many problems in the stomach. It can cause gastritis, chronic gastritis. It can cause peptic ulcer disease. And it can cause carcinoma of the stomach. Okay. It will not cause cancer of the duodenum, but stomach cancer it can cause. Adenocarcinoma also, maltoma also, both. Not only maltoma. In fact, adenocarcinoma more. How to differentiate? You cannot. Hard to differentiate. There is this classification you can read later if you want. This is called Johnson's classification. It is based on the location of gastric ulcer. So there are these Johnson's types. I'm not going to dwell on it. You can read it from the notes if you want. The clinical presentation, whether it is gastric or duodenal, is not very different. They used to say that gastric ulcer, when you eat, you get more pain. Duodenal ulcers, when you eat, the pain gets relieved. ऐसा नहीं होता. It's not very classical. So that is old teaching. The important thing is you get a pain in epigastrium. It can be after meals also. It can be relieved also by meals. It doesn't matter. But more importantly, the pain will be periodic. Like how you will get this pain in this period near your exams. Once the exams are over, even if you are having alcohol, the ulcers will not be there. Your pain will go away. So basically, when the ulcers are active, you get pain for a few days or weeks. In your case, for months, maybe even years. आप लोग का भरोसा नहीं. But once the stressors go, I don't know if your stressors go, then the pain goes because the ulcers heal. So ulcers become active, they heal, active, heal, active, heal. As it's a cycle. Like your mental status. Sometimes you are very active. Sometimes you're like, छोड़ो क्या पढ़ा रहे सर जाने दो तेल लेने दो. So that way ulcers behave the same way. So you know what you are, right? So there will be periodicity. Weight loss may or may not be there. If there is a sudden weight loss, what will you think? What will you think if there is a sudden weight loss? Patient says, in the last 2 months, I have lost 7-8 kilos of weight. That means the ulcer maybe has undergone a malignant transformation. Maybe it's possible. This can happen only in stomach cancer. The duodenal ulcers don't undergo cancer. Only stomach ulcers can become cancerous. Then you will investigate. You need to do only one investigation for ulcers. That is going to be endoscopy. But whenever you do endoscopy, you also look for H. pylori. For H. pylori, you do an antral biopsy. So you take a biopsy from the antrum and you put it on that slide. I have shown you that slide for the rapid urease test. Okay, it's not breath test. Huh? It is put on the slide. Rapid urease test. Upper GI bleeding most common cause karenge. We will get there. Yeah, CLO test. It's also called CLO test. But the principle is RUT, rapid urease test. So it will tell me that yes, there is H. pylori in the stomach or not. But the important thing is the biopsy is taken from the antrum. Please don't say breath. Okay. Or don't say stool sample. Those are for serological tests. Okay, so you can do serology for H. pylori antigen antibody. You can do stool test for H. pylori antigen. You can do breath test for urease, but the one that is preferred is antral biopsy because that is where the H. pylori is sitting. Treat peptic ulcer. It's simple. Medical management is the treatment of choice, where you will give PPIs. And if he is having H. pylori, you will give anti-H. pylori eradication or H. pylori eradication, the triple therapy. Okay, that will be given if he has H. pylori. Normally, like I would say 90% patients, 99% patients will be managed like this. Some cases you will have to do surgery. Surgery, rarely required. Very rare. Usually it will be done if he gets recurrent ulcers. Like everything you did, you stopped giving exams, you stopped smoking, stopped alcohol, everything stopped, still getting ulcers, recurrent ulcers, or if the ulcers start causing complications. Peptic ulcer bleed, peptic ulcer perforation. That is dangerous. Only in these cases you will think about surgery. Otherwise not. All right. Now what surgeries you are going to do depends on this principle. Mucous barrier, acid. Whatever surgeries we describe, vagotomy, antrectomy, they are all for duodenal ulcers. Because in duodenal ulcers, acid is high. So whatever acid lowering surgeries you do are only in duodenal ulcers. For gastric ulcer, acid lowering doesn't matter because the problem is in the mucous barrier. So for gastric ulcer, you will not do acid lowering surgeries. Okay, so please be very clear. Gastric ulcer, if you are doing surgery, it will only mean to resect the ulcer part. That's it. You have to resect the part of the stomach with the ulcer. Bas. Only for duodenal ulcers. Only if it's duodenal ulcer will you do acid lowering. So first be very clear about this part. Whatever surgeries I'm going to tell you now are only for duodenal ulcers. You can do it in two ways. One is this. One is based on vagotomy. And other is based on removal of antrum. This part, the distal part of the stomach, that is going to be excised. That is called antrectomy. Okay. Vagotomy, there are two types. The first one is I ligate both the vagus nerves at the origin at the GE junction. That is called truncal vagotomy. It's a very strong procedure, truncal vagotomy. But the problem is when I cut the vagus, the pylorus stops opening. You get an achalasia of the stomach. So whenever I cut the vagus, stomach will also become achelastic. It is like a achalasia of the stomach. So I always have to add some kind of a drainage procedure. Can't just do truncal vagotomy. I have to add a drainage procedure. Because I've added a drainage procedure, there are many complications. Complication rates are high. On the other hand, I have another alternative. I don't do truncal vagotomy. I ligate the individual nerves and spare the crow's feet. That is called as highly selective vagotomy. Okay, highly selective vagotomy. In this case, I spare the pyloric branches. Pyloric nerves are spared. And because I'm sparing the pyloric nerves, no drainage is required. And because there is no drainage, complications are very low. Less complications. Less complications. It will not cause too much acid lowering. So there can be some acid left, but complications are very less. It is the best tolerated procedure. Tolerance is very good. Patient acceptance is very good. Because he will not have dumping, he will not have vagotomy diarrheas. वो सब problem नहीं होंगे. Recurrence can be a little higher, possible. But you can give PPI ना, if you feel there is recurrence. So complication नहीं होना चाहिए. If I want, I can teach you the whole of surgery non-stop, धनाधन, and I teach you for 24 hours. समझेगा नहीं कुछ. क्या फायदा? दिमाग की दही हो जाएगी. Complicate हो जाओगे. You will start hating me. But if I teach you specific things, selective things, You may miss out on some things, but complication नहीं होगा, दिमाग खराब नहीं होगा. So it has to be balanced. Some people want me to teach for 24 hours, right? But it doesn't matter. Selective or highly selective, acceptance will be more. It is the most accepted procedure, right? You are happy now to learn all subjects in 4-5 days. Same thing. Drainage means if the pylorus is not opening, then I have to open the pylorus surgically. That is called happen that there is no acid production, but food also doesn't pass. So I cut the pylorus, make it a little bigger. That is called pyloroplasty. But whenever I do a drainage procedure, more complications happen. Right? So that is one group. Other group of surgeries are I remove the antrum. Like remember in stomach we did subtotal gastrectomy, something like that. I resect this much part of the stomach. This part is from where you get gastrin. Okay, gastrin is coming from here. So if I have removed it, gastrin levels will fall. If gastrin levels fall, acid levels fall. So antrectomy, whenever I remove the antrum, that is antrectomy, and I join whatever is left, the stomach and duodenum, in two ways. One is called Billroth 1, other is Billroth 2. Okay, in Billroth 1, I join the stomach to the duodenum. Stomach to duodenal anastomosis. In Billroth 2, I join the stomach to the jejunum, gastro-jejunal anastomosis. बस इतना ही है. This also has a lot of complications because I have done a gastrojejunal anastomosis. Billroth 2 में DM क्या होता है? Diabetes mellitus. Overall best बताऊंगा, don't worry. नहीं, not diabetes mellitus. वो नहीं होगा. Dumping सारे में होती है. All can cause dumping. Least dumping will be seen in highly selective vagotomy. I'll show you the table. You are asking, na, this is the table. This is from Bailey. Someone wrote this. Best, worst, whatever. Best, worst, you look at this. Operative mortality and side effects are the least. Okay, are the least with this procedure. So least complications. Highly selective vagotomy. Recurrence can happen 2 to 10%. है थोड़ा recurrence compared to other procedures. It is there, but least complications. Most powerful procedure. Most powerful is going to be a combination. I do both. I do vagotomy also. I do antrectomy also. That will have most power. Most powerful. Okay, it's like me teaching you 24 hours non-stop. Okay, and someone else teaching you surgery non-stop. Two people teaching you surgery. Sir, this Billroth is for GU, not for DU. No. If I have done antrectomy, it is for duodenal ulcer. If the ulcer was in the stomach, in the antrum, and I did antrectomy, I have removed the ulcer. So it can be done for both. But the principle for antrectomy is reduce the acid production. So duodenal ulcer. So most powerful, vagotomy and antrectomy, you can see recurrent ulceration is the least. Side effects भी तो ज़्यादा हैं, है ना? On every other day he'll have some problems. So question में कौन सा mark करना है depends on what they are asking, and I'll give you example. You want example? Take example. Adult male presents with duodenal ulcer, various surgical options, which has the least side effects with good healing. Good healing, but least side effects. So answer is going to be highly selective vagotomy. ये जो gastrojejunostomy है ना, in some other places they will tell you this as the answer, but let me tell you, this will not heal ulcers. It's not an ulcer procedure only, just DJ. To heal the ulcers, either you do vagotomy or you do antrectomy. Antrectomy तो करनी है, दोनों में से एक चीज तो करोगे ना. What is gastrojejunostomy? Antrectomy has to be there. Okay, I saw this on one other app. I forgot which one, where they gave the answer as D. I forgot, one of the students told me. But just GJ will not reduce the ulcers. Okay, unless it is some misinterpretation of the question. GJ is not for ulcers. Yeah, excellent, Brijesh. Okay, someone was asking this. You passed your exam, you go for party. I saw yesterday you were all saying मैम के साथ party करेंगे. मेरे साथ तो किसी ने बोला ही नहीं. मेरे साथ तो party करनी ही नहीं है. पास होना है लेकिन मेरे साथ नहीं करनी है. I was saying, I have to keep my eyes open. After this binge drinking episode, he presents with vomiting and upper GI bleed. What has happened? Binge drinking. Very good. It is Mallory V stare. All right. Now, where upper GI bleed, someone was asking, most commonly occurs due to duodenal ulcer bleed, DU bleed. This is the most common cause of upper GI bleed. It's DU bleed. But if a history like this is there, where you have binge drinking and then hematemesis, it is Mallory V stare. So what happens is when you do binge drinking, binge means एक time बहुत पीना. You become intoxicated, like you must have become on New Year's. Ulti, you start vomiting. You keep vomiting. And a time comes when you start retching because there is no vomit left. पेट खाली हो गया करके. And a time comes where you are retching so much, the stomach starts tearing the mucosa. You get a tear of mucosa at the cardia of the stomach. And this leads to submucosal bleed. It's submucosal. Okay, the bleeding is submucosal. So you get a submucosal bleed and he gets hematemesis. Don't worry, nothing will happen. This bleeding stops by itself. Okay, this bleeding stops by itself. So don't worry about it. This will happen because of tear at the cardia and it is a submucosal bleed. Okay, ये जो duodenal ulcer की bleed होती है ना, it's a dangerous bleed because it's an arterial bleed. Forest classification. This is because of gastroduodenal artery. So DU bleed will not stop by itself because it is due to gastroduodenal artery. It's obviously dangerous. You have to manage it endoscopically. In Boerhaave, there is no bleeding. Boerhaave is a very different disease. Boerhaave mein, there is a perforation of the esophagus. Okay, here is the diaphragm. Boerhaave happens because of vomiting. It's not because of bleeding. There is vomiting when the cricopharynx is closed. So there is a closed cricopharynx. So what will happen is this part will be closed. It happens if you are intoxicated. Again, intoxication. And you start vomiting. Now the problem is you vomit, but there is no place for the vomit to go out. फंस गई वो esophagus में. And in this case, the esophagus will tear on the left side in the lower part like this. So left lower esophagus will tear and things will start leaking. So in Boerhaave's, you present with mediastinitis, not with hematemesis. Okay, so it ruptures, things leak into the esophagus, you get the triad, Mackler's triad, chest pain, subcutaneous emphysema, breathlessness, vomiting. So that is what is seen in Boerhaave's. It is going to be seen due to a tear at the left lower wall of esophagus. And you present with a Mackler's triad. And obviously, esophagus has torn. This has to be managed surgically. You do surgery and you suture it. Variceal bleed will be seen in alcoholics with ascites, with splenomegaly. X-ray having upper GI perforation will be DU bleed. No. Tanuj, bleed and perforation are different. Bleeding में X-ray is normal. Perforation करेंगे, don't worry. Perforation आना है. Okay, so be very clear. No, anterior and posterior bleed. LGA का bleed if it's a gastric ulcer bleed, but it's very rare. क्यों होगा? Stomach ulcers don't bleed normally. You remember gastroduodenal bleed, that artery. It's a bleeding from GDA. Okay, so that is about Boerhaave syndrome. Mallory V stare. Mallory V stare will present with hematemesis. Boraf syndrome will present with perforation of the esophagus. Now come to peptic perforation, which you are mixing with Boraf. Peptic perforation happens usually when the anterior duodenal ulcers perforate. It is usually seen due to anterior D1 ulcers. They are the ones which will perforate. Stomach ulcers can perforate, but that's not so common. So an ulcer here in the anterior wall of the duodenum can perforate. And when it will perforate, the person will present with peritonitis. So this will be very classical, this peritonitis. He will present with acute abdomen. The key word is acute abdomen. In surgery, there are only 4 or 5 diseases where you get acute abdomen like this. So he will say, suddenly he gets acute onset pain, sudden pain. He may start vomiting. And when you are going to examine him, you get a classical finding on examination. Anybody can tell me what that is? The examination finding. If the ulcer perforates. Sir, bleeding posterior wall, perforation anterior wall, yeah. Because the gastroduodenal artery is on the posterior wall. So obviously it will bleed only in posterior ulcers. Anterior में कोई artery है ही नहीं, तो bleed कैसे करेगा? Yeah, so on examination, there will be rigidity, cardboard-like rigidity. There will be features of peritonitis, rigidity, diffuse tenderness. Wherever you touch, it will be tender. It is truly an acute abdomen. So whenever a person comes with acute abdomen and you think it is a perforation, how are you going to manage? You will investigate. First, you stabilize them. Give him IV fluids, stabilize them, put a Ryle's tube. And to investigate, the first step is going to be X-ray abdomen. It's actually X-ray chest with abdomen, upper abdomen. And you will see this very classically. So you can see this is the right dome of the diaphragm. You can see this black area over here. Uske niche is the liver. This black area over here, it's also seen on the left side. This is the left dome. You can see this black area over here. You will see free air. So you see free air or free gas. More importantly, right dome. Left dome में दिखे ना दिखे, right dome में दिखना चाहिए. Because left side, it can sometimes be the stomach fundus also. Sometimes. So if you see on the right side, you are worried that, oh shit, acute abdomen with free air, pneumoperitoneum, it means there is a hollow viscous perforation. So if I see free air, I will straight away do surgery. Laparotomy, wherever is the perforation, suture the perforation. And if it's a duodenal perforation, which you expect it to be, you put omentum on it. You do omental repair, omental patch. That is called as Graham's repair. If I don't see free air, okay, let's say patient has peritonitis. Yeah, very good, Shubh Patel. If I don't see free air, then do CT scan. Okay, if I see free air, nothing to do. If I don't see free air, then I do CCT. Obviously, this is the investigation of choice, but what I'm trying to tell you is CCT is not required if you have an X-ray which is telling you there is pneumoperitoneum. फिर करने की जरूरत नहीं. Right? So that was about perforation. Anteriors perforate, posteriors bleed because anteriorly there is no artery. The gastroduodenal artery is posterior. Right? Okay. Answer this. Patient presents with severe abdominal pain, vomiting. His vitals are stable. The radiograph is shown. Most effective way to treat the patient is going to be here also. You can see this free air, liver के ऊपर, resuscitation and laparotomy. This is FMGE Jan paper. Let's see if you can answer this. Quite a nice question. Why are you saying it is ileocecal TB? If I may ask. Why ileocecal TB? Most common site. नहीं TB ऐसे क्यों बोल रहे हो? Yeah. So a young patient, young like me, presents with a history of low-grade fever, anorexia, weight loss, and this barium is done. आज के ज़माने में you will not see this on barium, you will see this on CTM, but image shows barium, FMGE. What is the diagnosis? So what you are seeing here is the IC junction has gone high up. IC junction should be here, right lower quadrant. It has gone up. So your IC junction, instead of being here, has gone up. You can see this part, the terminal ileum is narrow. And just proximity it is dilated. This is typical of ileocecal TB. It is usually going to be seen in young females with poor immunity, malnutrition. And the presentations are very non-specific. You get ulcers in the ileum. So the person will present with right iliac fossa pain because of ulcers, and she will present with diarrhea. Normally, but this TB can form strictures. So if they form a stricture, there will be intestinal obstruction. That is how they will present. Okay, and to diagnose it, you can do biopsy. You will see the granulomas. Fever, Crohn's, how to differentiate? Crohn's very hard to differentiate. Okay, very hard to differentiate. So this presentation can be seen in Crohn's also. It can be seen in TB also. One of the ways to differentiate is if you are suspecting Crohn's. Crohn's will not be seen in a young, poor immunity, immunocompromised patient. It will be seen in a normal female. If you are suspecting Crohn's, you can do two things. One is in the stool, other is in the blood. In the stool, you will get a marker of Crohn's, which is called fecal calprotectin, which won't be seen in TB. It's a marker of inflammatory bowel, fecal calprotectin. In blood, you can do CASCA. Biopsy will show granulomas in both. दोनों में आपको granulomas मिलेंगे. But if you get caseation, it is TB. If you get non-caseation, it is Crohn's. It's not very unique. It's not very unique because in TB you can get non-caseating granulomas also. So trust me, not very easy to differentiate. Creeping fat sign, Aishwarya, when you do surgery, you will see ना. तो surgery के time पे पता चलेगा. पहले नहीं पता चलेगा. अगर surgery नहीं कर रही हो तो you won't see creeping fat. है ना? That is the problem. So undoubtedly they are difficult to differentiate. But yeah, in Crohn's on biopsy, in Crohn's, you will see non-caseating granulomas. And in TB, you will see caseation. That is fine. The treatment is very different for both. In TB, you will treat with ATT. In Crohn's, you will give immunosuppression. So drastically different. Yeah, this is string sign. Absolutely right. This is string sign. Narrow terminal ileum is string sign. That again is seen in both. Okay, it's a sign of ileal stricture. So you can see string sign in both, unfortunately. So hard to differentiate. Yeah. Okay. Now something easy. You've done many difficult things. So we will do something easy. Then I'll give you 5 minutes break. I also need a little break. Appendicitis. This is typically seen again in young boys. Young boys like you, or maybe even younger than you. Usually teenage boys. And it typically happens because of obstruction of appendix. The base of the appendix, ऐसे होती है appendix, it gets blocked. So when it gets blocked, the appendix will get inflamed, distended, collected, and this obstruction typically happens because of lymphoid follicles, Peyer's patches, they block it. Or it can happen because of some worms. Or it can happen because of fecoliths. If an adult, 50, 55-year-old, presents with acute appendicitis, what will you think? उसके तो lymphoid follicles hyperplastic नहीं होंगे. Someone who is 60 years old, diagnosed with acute appendicitis or features of appendicitis, what will you think? Just इनसिंग ट्यूमर नहीं आयुषी अपेंडिक्स पे तो मेटास्टेसिस नहीं होगा. You are not using your brains. Use your brains. I have been teaching you the same thing. Elderly. You see elderly with appendicitis, you will think of adenocarcinoma of appendix. Or you will think of carcinoid of appendix. Okay, either it will be adenocarcinoma of appendix or it will be carcinoid of appendix. Which is the most common tumor of appendix overall? Most common cancer of appendix. AD. No, it's not AD. It is carcinoid. Okay. Most common tumor of small bowel is adenocarcinoma. Carcinoid is the most common tumor of appendix. And the most common site of carcinoid in GIT is appendix. All this is pathology. So carcinoid का most common site is appendix only. Okay. So 60-65-year-old appendicitis, please don't think it is हमारा appendicitis. Okay. It's unusual. It could be a cancer. Now, easy part is how will the person present with appendicitis? Typically, the person will present with right iliac fossa pain. The person has RAF pain, typically, which started at the umbilicus and migrated. So you call it migratory pain. Migratory RAF pain means it started at the umbilicus and then shifted over here. He will have vomiting. He will have low-grade fever. What is this called? These three things together. Low-grade fever, right iliac fossa pain, vomiting. Excellent. This is called as Murphy's triad. Where do you see Murphy's sign? It's called as Murphy's triad. Where do you see Murphy's sign? It is seen in cholecystitis. So cholecystitis, you get right upper quadrant pain, which when he takes a deep breath, he winces in pain. That is Murphy's sign. Diagnostic of cholecystitis. Murphy's triad. Yeah, Murphy's eye and endotracheal tube. Wow, कल की class का असर दिख रहा है. So this is Murphy's triad. Pain, vomiting, fever. You get some signs also, like you get tenderness in right iliac fossa. That is the hallmark sign. But more importantly, you get rebound tenderness. What is this called? Rebound tenderness. This has a name. This is called Bloomberg sign. The tenderness in the right iliac fossa, uska sign का नाम नहीं है. It happens at the McBurney point. The site of the tenderness is called McBurney point. Okay, यहाँ पर होती है जो 2/3, 1/3 spino-umbilical line. That is McBurney point. And sometimes you get pain on pressing left iliac fossa. You give pressure in left iliac fossa, he gets pain in right iliac fossa. That is called as Rove-Singh sign. ये तीन साइन पता होने चाहिए. Tenderness at McBurney point, rebound tenderness, and when you press left iliac fossa, he gets pain in right iliac fossa. That is called as Rove-Singh sign. Okay, lumbar is rebound tenderness. You press in the right iliac fossa, and when you release it, he gets pain on release. That is rebound tenderness. They are the telltale signs of acute appendicitis. Okay, so this came FMGE Gen. Site of maximum pain in acute appendicitis is going to be McBurney. Okay, it's not umbilicus. Huh? Umbilicus is where the pain starts. McBurney point is where the pain migrates. It migrates to McBurney point. Okay. Then they ask you, how will you confirm your diagnosis? So the investigation, the first investigation is going to be ultrasound, abdomen. If they ask you investigation of choice, it's different in child, it's different in adult. In a child, it will be USG only, but in an adult, it will be CC. Okay, in an adult, it will be CACT. Why are you doing CACT? For what? जरूरी है CT करना? नहीं नहीं, मैकल्स नहीं सर, बट यूजली CT नहीं करते हैं, पता है मुझे क्यों नहीं करते, करना चाहिए एडल्ट में. It is done for two reasons. One is to rule out cancer, and second is if you are suspecting appendicular lump, you are suspecting appendicular lump or appendicular phlegmon. That is a complication of appendicitis, appendicular lump or appendicular phlegmon, because in that case, you are not going to do surgery. So the treatment depends on the severity. If there is only acute appendicitis without any complication, what are you going to do? Appendicitis which is uncomplicated, just inflammation same. Yeah, then you will do conservative management. Very good. I am happy you know this. You will do conservative management. If there is acute appendicitis with complication like gangrene, perforation, then you will do lap appendicectomy. And if there is appendicular phlegmonous appendicitis, means there is a lump. The appendix has gotten covered by omentum. Very good. You will do Ochsner-Sharon regimen. Wonderful. Excellent. You will do Ochsner-Sharon. Many NEET PG students also don't answer this like you are. You will do Ochsner-Sharon regimen. And once the lump disappears, after say 4 to 6 weeks, and then you will do interval appendicectomy. All right. In that case, you will do interval appendicectomy. Okay. This is how you are going to manage appendicular phlegmon. Yeah. And just one question, then I'll give you a little 5-10 minutes break. Which of the above incisions is preferred cosmetic in pregnancy? Appendicectomy. Management is the same. If it's uncomplicated, conserve. If it's complicated, obviously operate. Remember, in pregnancy, mother takes preference. Okay, mother takes preference. Keep it simple. Which of the following is cosmetically preferred is Lance. Gridiron and McBurney are the same. So gridiron is same as McBurney. It's not actually McBurney. It is called MacArthur incision. It's not a McBurney incision. It's a MacArthur incision, which is the muscle splitting incision. It will not cut the muscle. It will split the muscle. This Morrison incision is a muscle cutting incision. And Lanz incision is the cosmetic one. It's a skin crease incision. All right, so the answer is going to be Lanz. Fine. So be very clear about these incisions and their names because they come a lot in the exams. Okay, so which is commonly done is laparoscopic appendicectomy. None of these are done. What is commonly done is lap appendicectomy. Oops. Okay, so take 10 minutes break. 12:15 I will come back. Sawa 12. 12:15. Okay. Okay, guys, let's move on. Hope you're back. You will get your lunch break at 2. Yeah, let's rock. Okay. So answer this one. I have a feeling you will get something on this topic. अंदर से feeling है मुझे, क्योंकि बहुत टाइम से इस पे कुछ आया नहीं है. Patient presented with nausea, vomiting, fever, diagnosis appendicitis, incidentally found. What is this? So if you get some image you can't understand, go to your basic anatomy. This looks like small bowel, right? This is small bowel. It does not have tinea coli, so it's not colon. And there is some straight looking outpouching from the small bowel. Small bowel outpouching should be Meckel's diverticulum. Now, what should you know about Meckel's diverticulum? Typically, forget about the rule of tools. I'll tell you what you should know for exam. It comes on the anti-mesenteric side. This is the mesentery. You can see this. It will bulge on this side, the anti-mesenteric side. Usually, it will be 2 feet from IC. So it is a ileal diverticulum, 2 feet from IC junction. And the other thing that you need to know is it contains usually gastric epithelium or pancreatic epithelium. And because it contains gastric epithelium, this gastric epithelium, if it contains, will form ulcers. It will produce acid, it will form ulcers like peptic ulcers, but in the ileum. So, agar isme there is gastric epithelium, it will produce acid. Acid will cause ulcers over here. And these ulcers can cause bleeding. So, there will be PR bleeding. But who will present with this PR bleed? A child will present because it's a congenital diverticulum. So it will be seen in a child, not like you, a child, typically 5 years of age, 4 5 years of age. So PR bleed, elderly smoker male, colorectal cancer, PR bleed, someone young like you, ulcerative colitis, PR bleed in a child, much younger, maybe your son or daughter, if you have, will be Meckel's diverticulitis. Okay? So that is what you need to know. A child presenting with PR bleed will be Meckel's diverticulum. It is a congenital diverticulum. And the other thing you need to know is if this happens, the investigation of choice to diagnose this is going to be your technetium 99 RBC scan, which will show you the ectopic gastric epithelium. It will show you the ectopic gastric epithelium in the diverticulum. So it will show you stomach. It will also show you where this epithelium is somewhere else in the intestine. So you know, oh, there is Meckel's diverticulum over there. Okay, that is the investigation of choice. Treatment will be surgical removal if it is causing a problem. What is this Inch's classification? Where is it used? This was asked before. Inch's classification कहाँ पे होती है? PAN. No, yeah. So in your sigmoid colon, you get diverticuli which are false diverticuli or acquired diverticuli. False acquired diverticuli. They are because of increased pressure. Okay, they are because of increase in pressure. And they are only in the mucosa. So this is your sigmoid colon. And where you have the sigmoid colon, you have the mesentery of the sigmoid, from where the blood vessels are coming. On the mesenteric side, you can get mucosal outpouchings. So these are going to be false, so they are only mucosal. They are acquired and they will be on the side of the mesentery of the sigmoid. This use of anti-mesenteric, true, complete, all layers, anti-mesenteric. This will be false, mesenteric side. And of course, they are going to be seen in adults. Normally, these diverticuli don't cause any problem till they get perforated. So the problem will only happen if they start getting inflamed and perforated. They get inflamed because of stasis. One of them will get perforated and things will start leaking. This is Hinch's classification. It is a classification of perforated sigmoid diverticulum. Okay, perforated sigmoid diverticulum. Why do you get diverticuli and sigmoid colon only? Not anywhere else. Yeah, Rizwan, right? Sawtooth sign. That is a PYQ. Why in the sigmoid colon only? Why not rectum? They are because of increased pressure. So increased pressure should be in the rectum, sigmoid both. Why not in the rectum? Why in the sigmoid colon? Some reason, no? If you know the reason, you'll remember it forever. Because rectum has a very thick muscle layer. So it will not let the mucosa go out. Sigmoid little, sigmoid can stretch. It is more distensible. So if it can stretch, the muscles can also stretch, the mucosa can outpouch. That's why sigmoid colon is the most common site. Because it is stretchable, the muscles can get stretched. Rectum will not stretch, it has very thick muscles. आई बात समझ में? ऐसे समझो कुछ नहीं आपको कभी नहीं भूलोगे. So these diverticuli are in 4 stages of hinges. In stage 1, whatever has perforated is collecting only around the sigmoid colon. So the collection, the leakage is pericolic. So you get pericolic abscess. In Hinchey class 2, the abscess will spread from the colon into the dependent areas. You get pelvic abscess. Then it will spread throughout the abdominal cavity. You will get purulent peritonitis, generalized peritonitis. That is going to be Hinchey class 3. And in Hinchey class 4, instead of pus, EC starts leaking out. So you get fecal peritonitis. Fecal peritonitis of any extent is going to be Hinchey class 4. All right. Normally, if I only have diverticuli, there is no problem. So clinically, it is asymptomatic. Normally, there is no problem. Clinically, it is asymptomatic. It's only when the diverticulum perforates, he gets some symptoms. So symptoms like left iliac fossa pain, diarrhea are features of perforation. This can progress to peritonitis, acute abdomen, if it has spread in the abdomen. And sometimes you can get bleeding. So you can get PR bleed in the diverticulum. This again will be seen in adults. So elderly patients with PR bleed, if it's not colorectal cancer, it will be diverticular disease. Both will be diagnosed on colonoscopy. So colonoscopy in an elderly male with PR bleed has to be done. That's the message. How to diagnose? Easy. It looks like this. You can diagnose it on colonoscopy. That is the investigation of choice. So you will see these outpouchings. And when they bleed, you can see the blood also coming inside from the diverticulum. And you can either see it on CT or you can see it on this image. This is called barium enema. I have put this image for a reason. This appearance is called sawtooth pattern. This one already told us. So this is a sawtooth pattern. You can see these spikes. They are the diverticular bulges. So you can see it on CT or barium enema. CT में भी दिखता है. And treatment is usually going to be surgery. You remove the sigmoid colon with the diverticulum. That is going to be the treatment. Sigmoid colectomy. Okay, sigmoid colectomy. That is what is going to be the treatment of sigmoid diverticulum. Yeah. Of any acute condition, you will not do endoscopy. Goes without saying. If it is acute, like a perforation, obviously you will do CT. That goes without saying. Okay. So this was asked in FMGE Jan 2021. History of constipation shows imaging. You can see these outpouchings. So this is sigmoid diverticulum. If they ask you the next step, what is your answer? What is the next step? Are you going to do sigmoid colectomy in her? Conservative. Now understand, if there is no complication, the management will be conservative. Don't do sigmoid colectomy if she's having no complications. Sigmoid colectomy is only if there is a perforation or if there is a bleeding. Asymptomatic incidental diverticuli are going to be left as they are. It's like saying when I do laparotomy, I see the appendix. Do I remove it? Of course not. सारे appendix थोड़ी निकालते. Appendix is also a diverticulum only. That doesn't mean every appendix you remove. You remove appendix when there is appendicitis. So you will remove diverticuli or sigmoid colon when there is diverticulitis. Okay, or diverticular perforation. That's it. Okay, so it is conservative. Just treat the constipation. Please use your common sense and common concepts and common understanding in surgery. You will make more mistakes if you just mug up the facts. You will get stuck. ऐसा ही scenario देंगे. Next time they will ask you next step. You have marked sigmoid colectomy, heart main procedure. You will mark that. And last option will be bulk forming laxatives. That is the answer. Okay. So please use some common sense. Only then you will get 25 out of 30 in surgery. Otherwise, you will get 15 out of 30. Then your burden is on other subjects. You don't want that, right? Colonic polyps, I feel, is a very important topic because in colon, you can get cancer from polyps. And these polyps can be benign polyps, like a inflammatory polyp or a hyperplastic polyp. They are all benign. They have no malignant potential. Or a hamartomatous polyp. They are all benign polyps. Or they can have a malignant transformation risk. So they are called as neoplastic polyps. Risk of becoming cancer, which you see over here. Those are your adenomas. Okay, these two types. Which is more dangerous, tubular or villus? Which is more dangerous, tubular adenomas or villus adenomas? Of course, villus adenomas are more dangerous, especially if they are more than 1 centimeter. They can become adenocarcinoma, undoubtedly. These polyps can happen by chance. Like you and me can be having some of these polyps, but some of us can be born with the polyps. Okay, those are called as polyposis syndromes. They run in families. So they are familial. They are autosomal dominant inheritance. Any disease which is familial, hereditary, will be autosomal dominant. So you can get syndromes like this one, which is called Peutz-Jeghers. Peutz-Jeghers. You can have a good look at this image. It will come in your exam. Peutz-Jeghers syndrome. In Peutz-Jeghers syndrome, you get hamartomas. Hamartomas are benign. So don't worry if you have Peutz-Jeghers. You get this lip pigmentation. Very classical in Peutz-Jeghers. You know the mutation, right? STK11. Mutation you know better than me. But important, it does not cause colorectal cancer because hamartomas are non-neoplastic. So there is no risk of cancer in hamartomas, but there is a risk of pancreatic cancer. Pancreatic adenocarcinoma risk is very high. This is the message I want to give you, that it is not going to cause cancer of colon or cancer of rectum, but it can cause cancer of pancreas. Not because there are hamartomas in the pancreas, huh? It's because of the mutation. So don't say, sir, do you get hamartomas in the pancreas? You have mutations which also affect the pancreas. So you get pancreatic cancer. The other two syndromes, I'm sure you know them very well. One is your FAP, familial adenomatous polyposis coli syndrome, FAP. It is because of this APC gene mutation. It has more than 100 adenomas. More than 100 adenomas. Adenomas will become cancer. So he has a 100% risk of adenocarcinoma in his life. 100%. And when will he get it? By the time he's 25 years. Means you will get it. So if by chance you have this APC gene mutation, by the time you are now, you would have gotten a colorectal adenocarcinoma in one of these adenomas, which is why you should do a prophylactic proctocolectomy. Okay, तो आपकी colonoscopy करा लो. If you have more than 100 adenomas, please remove your colon and rectum. You have to do a prophylactic total proctocolectomy. By the age of 20 years, you are a little late, unfortunately. थोड़े late हो गए हो, पर colonoscopy करा लो, just to be safe. And the other is called HNPCC. In this is again going to be autosomal dominant. It has those MLH, MSH mutations. Mismatch repair. Those genes are mutated. Here you have few adenomas. Okay, not many. Fewer adenomas, lesser risk. So lifetime risk is about 80%. It's still very high. Huh? It is 80%, but it is still very high. And this will occur little later, the cancer, 40 to 45 years. So here you don't have to do any prophylactic removal. So if on colonoscopy you have less than 100 polyps, which are adenomas, 4 or 5 polyps, then don't worry, you can do surveillance. Okay, then surgeon will not get money. Who gets money if you do surveillance? Who will get money if you are doing surveillance? If I am not getting, someone else has to get it, right? Consultation, physician, gastroenterologist. You have to do surveillance colonoscopy forever. Okay, and any polyp, if it is dangerous, take it out. Whichever polyps come, take them out. Just take out the polyps. Right? So this is about the syndromes of colonic polyposis. Yeah, wonderful. They are asking this a lot in NEET, PG, and INI CET. So far in FMGE, they have not asked this question. Okay, so far. So I'll just tell you some tips, some important things. That when I have a rectal prolapse, it has to be operated upon. Which of these? It can be operated from below. It can be operated from abdomen. The perineal surgeries, okay, the perineal surgeries are going to be Altemeyer, Thiersch's, Delorme's. Ripstein is not a perineal surgery, it is an abdominal surgery. Okay, it is an abdominal mesh rectopexy. Okay, abdominal mesh rectopexy. These three are done from below. They are perineal surgeries. They look like this. So rectal prolapse looks like this, by the way. I hope none of you have it. If you have it, it's a problem. Please get it fixed. Tad या option देख के mark कर रहे हैं. पता नहीं ऐसे क्यों कर रहे हैं. This surgery, this image has been asked before. So what they do is they take a stitch around the anal canal. They take an anal stitch that is called as Thiersch's anal wiring. Actually, they used to use a wire. They would wire the anal canal. Take a stitch around the anus, make it tighter so that the rectum does not come out. That is called Thiersch's anal wiring. This surgery, whatever rectum has come out, they would suture it like this. Take those first-train type of sutures. This is called as Delorme procedure. Okay, Delorme procedure. It is a type of a plication of the rectum. And the third one, from your TAD bit, is Altemeyer procedure. In Altemeyer, they would resect whatever has come out. It is a resection. So whatever the rectum is out, you cut it out and then you suture it. So it was a resection rectopexy. These three are your perineal surgeries. They can be done from below, as you can see. The abdominal surgeries are basically your mesh repairs like this. There you have Ripstein. You have Wells procedure. खाली नाम बता रहा हूँ. Basically, they are done from the abdomen. You pull up the rectum and you put the mesh. So what will happen is the rectum will get stuck to the mesh and then it will not fall down again. Okay. Obviously, these surgeries have good outcomes. So they are preferred in young patients, young fit patients. Perineal surgeries are done in older unfit patients because their long-term outcomes are not so good. But in an elderly unfit patient, you don't need a lot of long-term outcomes, so you can manage with it. Right? So these are the surgeries for rectal prolapse. Now another part of acute abdomen is going to be intestinal obstruction, जिसमें सबसे important I feel is paralytic ileus. Whenever you study intestinal obstruction, the first question that you need to ask, yeah, it is called Ivor sponge. Yeah, you're right, Shubh Patel. I wonder where you heard that term. It's not given in Bailey. It's an old term. It's called Ivor sponge. You're absolutely right. So whenever you think about intestinal obstruction, the first question you should ask is always, is it a mechanical obstruction, like a stricture, a tumor, or is it a functional obstruction? Paralyzed intestine. Okay, it is not having peristalsis. That is the first thing. So paralytic ileus is a functional obstruction. There is no tumor, stricture, foreign body. Peristalsis is not happening. Now, why will peristalsis not happen? The most important risk factor is going to be post-surgery, post-laparotomy. Because when I do a laparotomy, the intestines are exposed to the environment. I open the abdomen, suddenly all the intestines are exposed. So they are stunned. And because they are stunned, they don't come back to action. So when I started the class, I started giving you all those bhashan. Okay, don't interrupt, don't do this, don't. So you must be a little stunned. Achanak sir ko kya ho gaya? So initially nobody was putting any comments because you were stunned. But slowly you realize sir is going back to his old self. So you started passing comments again. So peristalsis comes back. Eventually your inherent desire is to comment. So your inherent desire will take over. So your peristalsis always comes back. Post-laparotomy is the most common cause of paralytic ileus. Other causes, let's say the zoom goes off. Zoom band ho gaya. You can't see me, I can't see you. Means there is ischemia of the bowel. No blood flow. Or someone said chinapia, I may be hypokalemic. Or if we start throwing too much poison at each other, if there is peritonitis, burns, septicemia, there will be paralytic ileus. So paralytic ileus typically has a very telltale history. Okay, it has a very telltale history. It will not happen just like that. Some predisposing conditions should be there. And in paralytic ileus, since the intestine is not having peristalsis, you will have distension of abdomen. That is the main finding. You may have vomiting. Okay, you may have vomiting. And of course, there will be constipation, obstipation. What is classically missing in paralytic ileus, which will not be seen, which is seen in mechanical obstruction, classically? Yeah, it is painless. Why should there be pain? If there is paralysis, why should there be pain? So it is typically going to be painless. Even when I palpate the abdomen, there is no tenderness. And to show that there is no peristalsis, there should be absent bowel sounds. Right, the bowel sound should be absent. That's how I know that there is paralysis. Like LMN, you do all the reflexes, there is no reflex coming. That is LMN. So paralytic ileus is like LMN of neurology. Mechanical obstruction is like UMN. Everything is hyper, exaggerated. Yeah. So UMN, LMN, this is LMN. Yes. So clinically, I come to know, is there paralytic ileus? To confirm, there is of course going to be a history. The first step that I'm going to do, obviously, is going to be in any patient with suspected obstruction, is going to be X-ray abdomen. Right? And I'm guessing you would have studied X-ray abdomen findings of paralytic ileus I'm sure Madam taught you this week only. So X-ray abdomen in paralytic ileus and mechanical obstruction are very different. Like in mechanical obstruction, you see this step ladder pattern, step right, step up pattern. This is mechanical, step up or step ladder. In paralytic ileus, there is no step ladder. And very commonly, you will see air in the rectum because there is no mechanical obstruction. There is no one point. Air will reach wherever it can. There will be air in rectum. There will be no transition. So X-ray gives me an idea whether there is paralysis or there is mechanical obstruction. What do I do in either cases? Yeah, whole bowel can be involved. Can be involved. It can involve whole bowel. It's possible. So what do I do in either cases? In either cases, if it's a mechanical obstruction, let's say like in this case, it's dilated till here. There is no dilation of the colon. Colon is collapsed. In mechanical obstruction, I am going to do CCT abdomen because I want to know the site of obstruction. I want to know, is there bowel ischemia? And based on CT, based on the etiology, I will decide what to do next. Does it need surgery? Does it need something else? If it is paralytic ileus, clearly on X-ray, then I will proceed with conservative management. Right, I will proceed with conservative management. Means put nasogastric tube, Tiles tube, decompress, give him IV fluids, correct his potassium, chai vai pilo, so potassium correction, and you wait for peristalsis to come back. Obviously, the comments will start coming back, peristalsis will start coming back. चाय पी लिया, खाना खा लिया, एनर्जी आ गई, पैरालिसिस चला गया. Mechanical obstruction, you have to do CT. First X-ray, then CT, not in all bowel obstruction. First X-ray, then CT in mechanical. First X-ray, if it's paralytic, no need for CT. How long does it take? Usually within 3 to 5 days. If the peristalsis doesn't come back within 3 to 5 days, if no improvement within 3 to 5 days, then you should hunt for some reason other than this. Maybe there is peritonitis that is causing the persistent paralytic ileus. So there is no improvement in 3 to 5 days, you are worried. Kuch gadbad hai. In that case, you will do CCT. Basically to look for leak or peritonitis. Because if there is peritonitis, then the paralytic ileus will not improve. Is there any role of enema? Barium enema? No, not in today's day and age. Barium enema has very select indications, not intestinal obstruction per se. So this is going to be your pathway. Patient with acute abdomen with features of obstruction, you examine him, think paralytic ileus or not, do X-ray, confirm. If it is paralytic ileus, conservative management. If it is mechanical obstruction, you need to know where is the obstruction, how bad is the obstruction, you will do CT. Yeah. Barium enema का part आएगा. Barium enema आ गया आपका, देखो. This is barium enema. So this important disease is called as intussusception. Okay, and this is typically seen in infants. Intussusception, infants. I know you like this kind of tricks to remember. It's not the right way to remember, but it's how, if you want, you can remember. That's not how I would remember it. It is seen in infants, basically in 6 to 12 months. Infants who are in the weaning period. Matlab, apart from breast milk, you are giving them other things, like other things to eat and drink. So it is seen in weaning period. And typically where it occurs, the common site in children is going to be ileocolic or ileocecal. So in intussusception, what will happen is the ileum invaginates into the cecum like this. And it can go higher up also. So there is an invagination of the ileum into the cecum. This happens because of those Peyer's patches only. The Peyer's patches will hypertrophy, they will start the intussusception. Typically, this will present with the mother will say, the child cries in pain, he holds his abdomen, he cries in pain, and after some time, he passes red current jelly stools. So red current jelly stools will be passed, very classical. And then the mother brings the child to you and you are going to examine the child. So when you are going to examine, many times this intussusception can be felt over here, like a sausage mass. And because it has come medially, this right iliac fossa is empty. So there is a empty right iliac fossa, which I'm sure you know, this is called as sign of dance. Right, this is called as sign of dance. Okay, not dancing sign, sign of dance. So child comes like this. How are you going to manage first investigation? What is the first step for intussusception? Yash Bala saying, okay. Yeah, don't do USG. Okay, let's not jump the gun. First, you are going to do X-ray abdomen, where you will see dilated small bowel loops. So you will see small bowel obstruction. ऐसी कुछ फोटो मिलेगी आप, ऐसी वाली बच्चे में small bowel obstruction, mechanical obstruction, not paralytic. Then after this, you can either do ultrasound or you can do CCT. पहले के जमाने में बेरियम ही नहीं. Ultrasound, you get this donut appearance, target sign. On barium and on CT, barium CT दोनों में, you can get this is called claw sign. This is called coil spring sign. If they ask you investigation of choice, go for CT. Okay, not ultrasound. Yeah. So you can diagnose it quite easily, and then you are going to treat. You start with high pressure enema. It may treat the intussusception. So that is a starting point, high pressure enema. If it works, well and good. If it fails, then you will do surgery. Right. The message I want you to take is not the science. The message I want you to take is this will present in the weaning period. Okay, 6 to 12 months, 13 months, 14 months, when the child is getting other feeds, because that is when he will get GI infections, he will get hypertrophy of Peyer's patches, and that will start the intussusception. Infantile pyloric stenosis, 1 month, 1 to 2 months. Rotavirus vaccine association, yeah, they may have taught you that in pediatrics. What is this? I put this on my Instagram also very recently. If you didn't see it, you should see this. This is coffee bean sign of sigmoid volvulus. Okay, this is coffee bean sign of sigmoid volvulus. Why is it not cecal volvulus? You don't see Instagram, so you suffer. Yeah, coffee bean sigmoid volvulus. Why is it not cecal volvulus? This is typically seen in elderly males. Elderly, constipated people. They get the sigmoid volvulus. Cecal volvulus is seen in children. Nothing to do with constipation. So what you see here, why is it sigmoid volvulus, is because there is a partition that represents the mesentery of the sigmoid. So when the sigmoid will twist, sigmoid is like this. Your normal sigmoid colon is like this. So when it will twist, the mesentery in between will also get caught, which you can see over here as the partition. Cecum is like this. ऐसी होती है ना cecum. So when cecum will twist, it will twist in this direction by itself. So there will be no partition in cecal volvulus. Sigmoid volvulus, there will be a partition, and sigmoid volvulus will fill the whole abdomen from left to right. The whole abdomen will be filled with the coffee bean. That's why you get this coffee bean sign. Okay, that's what I want you to know. Sigmoid volvulus, partition. Cecal volvulus, no partition. Sigmoid volvulus, elderly constipated male. Cecal volvulus in children. Okay, children will get cecal volvulus because only a child, the cecum will be mobile. Polocolic intussusception is the most common cause of intussusception in adults, but it's not very common. क्यों होगा किसी को? It's not so common. All right. And the last remaining part of GIT before we go to HPV is fistula in anus. All right, which I will give little importance to. Okay, little importance to, because if you understand just this one part, everything else is easy in fistula and anus. Understand fistula is happening as a complication of abscess. Okay, it's a complication of perianal abscess. It will not happen just like that. First, you should get an abscess. So, what is this abscess going to look like? So, it's like this. This is the rectum. This is the anorectal ring. ऐसे होती है. And this is the anal canal. So, just give me 3-4 minutes. You will understand this forever. If you already know it, it will be revised forever. You won't have to study it again. Okay, 5 मिनट में बता दूंगा पेरिनल एब्सेस के टाइप्स नहीं समझ में आते. This is the anal canal mucosa. Somewhere here is the dentate line. Then I have one sphincter surrounding the anal canal, छोटू सी sphincter, which is the internal sphincter. It goes like this. Okay, this is the internal sphincter. Outside the internal sphincter is a much bigger and more important sphincter, which goes like this. More important, more bulky. This is called the external sphincter. And outside the external sphincter is going to be the fat. This fat over here. That is your ischioanal fossa. So this is external sphincter. This is ischioanal fossa. This is my levator ani or pelvic floor. बस इतना ही ध्यान में रखना. Now, how does the abscess or fistula begin? It begins from these glands. You have glands over here, intersphincteric glands, which have ducts, which open in the anal canal like this. It starts off as an abscess in these glands, and the abscess will start spreading. Normally, the abscess will spread downwards. And it will open over here. So the abscess is entirely within the two sphincters. The fistula is entirely within the two sphincters between internal and external sphincter. And then it is opening internally like this. This is called type 1, Parkes type 1, or intersphincteric fistula. The name tells you the fistula. The tract is between the two sphincters, internal and external sphincter. The tract is in this plane. This is intersphincteric fistula. This is the most common. It is seen in almost 50% of the cases. Sometimes the pus can go outwards, and the tract, instead of going down, it goes out like this. And then it goes and opens a little far away in the ischioanal fossa. Over here. This has passed through the external sphincter. You can see the tract is going through the sphincter. So, since it is going through the sphincter, type 2 is going to be called as transsphincteric fistula. This is the second most common type. It is seen in about 40% cases. The other two types are very rare. Okay, don't worry about the other two types. The third type will be like this. It starts over here. Instead of going down, it first goes up, crosses the levator ani, then comes down like this. First went up, then came down. This will be type 3. ऊपर जाके नीचे, so it is crossing the levator ani and coming down. That is going to be type 3. Also called as supra sphincteric. Went above the sphincter, went through the levator ani. This is the third type, third most common. This will be seen in about 10% cases. And the fourth type is not an anal fistula. It's a rectal fistula, means it starts here in the rectum and goes out like this. It's actually a rectal fistula. This will be type 4. So it has no connection with the sphincter. That is called as extra sphincteric. It will be seen in less than 5% cases. So the first two fistulae are the ones which don't cross the levator ani. They are the common ones. They are called as low fistulae. Third and fourth type are high fistulae. Right? Low fistulae don't cross the pelvic floor. High fistulae cross the pelvic floor. इतना ही जानना है, बाकी सब easy. Patient will come with discharge from the perineal area. He'll have a wound with some discharge. So he will say, first I had an abscess, it used to pain, now there is some liquid coming out. When you see, you will see this, the external opening. You can see the external opening. You can do porectal exam. You can feel the internal opening. बस बात खत्म. पुराने जमाने में they used to use a rule, Goodsall rule, not used anymore. Old times, they used to use Goodsall rule. Don't worry about it. And that rule was to predict internal opening and predict the course of the tract. But nowadays, you don't use any prediction. Nowadays, if you want to know how the tract is, the investigation of choice is going to be, what do you do now? Instead of Goodsall rule, yeah, now the investigation of choice to know the course of the tract is going to be MRI, perineum. Okay, and the treatment of fistula is going to be surgery. Treatment is going to be fistulotomy or fistulectomy. You don't need to know details of the surgeries. Names are enough. Fistulotomy or fistulectomy. And if I can't do surgery, I can put some threads to inflame the tract and fibrose the tract. Those are called as cetons. You can do ceton insertion. What is the Indian ceton name? The Indian thread that you use, what is it called? To probe the tract? Confused between MRI and fistulography. Fistulography is when you just put a dye and you take an X-ray. Fistulography is an X-ray. MRI is magnetic imaging. Yeah, Shar Sutra. Excellent. You guys know the name. It is also called as Shar Sutra. Sutra का मतलब thread होता है ना, or a bond. Okay, it's not some other case sutra. Don't let your imagination run wild. ये bond वाला सूत्र है, Shar Sutra, not some other sutra, which also starts with a K. Please don't use these things to remember. Okay, एग्जाम में ये मत याद करना. हर चीज में आपको नहीं तो वल्गैरिटी चाहिए, है ना? Yeah. So this is about MRI perineum. Goodsall rule, if you want, I'll explain in the end. If you want, okay. If you wait till the end, that's your price. Not at this stage, right? So they asked this in FMGE December 2020, and MRI perineum was also asked. That patient presents with anal discharge. This is a picture. What is this device, by the way, which he is inserting? This is not Shar Sutra, just for your information. Yeah, this is fistula. And what is the device? Pigtail. Fistulogram is an X-ray. Prakash. Fistulogram is an X-ray. What is this device which he is putting in the fistula, which will Go inside the fistulous tract. Then lift is the name of the surgery. Kuch bhi. This is a device. It is called a fistula probe. It is used for probing the fistula. Like how you were probing me. You were probing ma'am yesterday. We want party. Yeah, so it's a fistula probe. You put the probe and then you remove the fistula around it. Okay. Probe करने में आप लोग उस्ताद हो ना. Alright. हमेशा एक क्वेश्चन हर्निया से आता है. So nothing can be complete without doing hernias. Hernia is actually general surgery, GI surgery put together. But we do it here. In your life, if there is one hernia you need to know, it is inguinal hernia. And in the inguinal region or the groin area, you can get three types of hernias. Okay, in the groin area, somewhere here, you have your inguinal ligament. Okay, ऐसे जाती है inguinal ligament. Something like this. Above the inguinal ligament, you have the inguinal canal over here. When I say hernia and I say inguinal hernia, it means the hole for the hernia is in the inguinal canal. Hernia means this, there should be a hole in the muscle. Defect. Through the hole, peritoneum is going out. Sac. Inside the sac, there may be intestine, there may be omentum, whatever the hell is there inside. Those are called contents. When I say hernia, there should be three things. There should be a defect, a gap, there should be a sac, peritoneum, there should be contents, intestine, omentum, whatever fills inside it. All hernias are named based on the site of the defect. So when I say inguinal hernia, the defect should be in the inguinal canal. It will either be a defect medially or it will be a defect laterally. That is inguinal hernia. Where is the defect? Inguinal canal. If the defect is below the inguinal canal, below the inguinal ligament, somewhere over here, below, that will be femoral hernia. Femoral hernia technically is in the thigh. Okay, thigh में होती है femoral hernia, abdomen में नहीं होती है. It's just called groin. So inguinal hernias defect is in inguinal canal. Femoral hernia defect is in the femoral area, also called as femoral ring. Now I'll tell you the types. ये समझ में आ गया ना? ये defect कहाँ है वो देख, इससे hernia समझ में आ जाए. Now have a look at this. This is the inguinal ligament. This is the inguinal canal. Okay, somewhere in between the inguinal canal, you have a blood vessel which runs like this. Inferior epigastric vessels. You can have a hole or a defect medial to it, this area. You can have a hole lateral to it, this area. So hernia can come from this hole, hernia can come from this defect. Those are the two types of my inguinal hernias. It is based on the defect size. So in the inguinal canal, if the defect is the deep ring, deep ring is a natural hole. Where is the hole? This deep ring. The hole is in what? It's a natural hole in the fascia transversalis. So if there is a hole in the fascia transversalis, which is going to be lateral to inferior epigastric, this hernia is going to be called a indirect hernia. Indirect inguinal. It is coming through a naturally occurring hole, which is the deep ring. On the other hand, if the defect is through this triangle medially, so if the defect is through the Hasselbalch triangle, which is medial to inferior epigastric, that is called a direct hernia. All right. So Direct versus indirect are based on the location of the defect. Which is more common, direct or indirect? Someone is writing something in chat, that's why I'm asking. He has aroused the question in me. Which is more common, direct or indirect? See, understand, indirect is coming through a natural hole. This hole is already there, the deep ring. It's a naturally occurring hole. So obviously, it is already there. Hernia can happen very easily from this hole. So indirect is far more common. Direct is not coming through any natural hole. It's coming through an area of weakness here, Hasselbalch triangle. So direct hernia is little less common. And the third type of hernia is below the inguinal ligament over here, where the defect is in the femoral ring. And this femoral ring is going to be below inguinal ligament. Okay, below inguinal ligament. This is going to be femoral hernia. आगे बात समझ में? All three of these hernias are in the same space, which is called groin. But the defect, two are above, one is below. If they ask you, okay, in female, most common hernia, what is the answer? Most common hernia in females? Yeah, what is the answer? Indirect. Indirect. Inguinal. See, understand. It's very simple. Overall, most common hernia, male and female. Whether it is male, whether it is female, the most common is going to be inguinal. If they ask you second most common after inguinal, it's not femoral, it will be incisional. Male ho ya female ho, kuch bhi ho. Then you have other hernias. Femoral hernias are seen more commonly in men and females. Are seen more commonly, but femoral hernia is very rare. Okay, it's very rare. It is seen more commonly in women compared to men, but it's not if women will have femoral hernias more commonly than inguinal. In women, inguinal. Second most common, incisional, not even femoral overall. But yeah, femoral can be seen more commonly in women. And they will put this in the question and you will mark femoral and it will be the wrong answer and you will say, sir, in my recall, I was getting so many, but in the result, I have gotten so many. Let's not do that. Okay, concept has to be clear. Below pubic tubercle or inguinal ligament, it's the same. So inguinal ligament hoti hai, it's attached here to the pubic tubercle and here to the ASIS. This is the attachment. So here it is pubic tubercle. Here it is ASIS. This is inguinal ligament. So it will be below all the three. Inguinal ligament also, pubic tubercle also, ASIS also. Basically below the inguinal ligament. You can't see the inguinal ligament. That's why you use pubic tubercle as an anatomical landmark on examination. Because you can't see the ligament, na? दिखती नहीं है वो. और ligament attached pubic tubercle पे ही है. अच्छा, now this named hernias. This is a wealth of MCQs. Named hernias. What is a Richter hernia? These are not based on defect. These named hernias, many of them are based on the content. I was telling you hernias are named on the defect. These hernias are named on the content. Whether it is inguinal, umbilical, paraumbilical. In a Richter hernia, the content is very unique. So if this is the peritoneum, in a Richter hernia, the part of the intestine, only a part forms the content, only a part of the wall. So if you see, only this much part of the intestine is inside the sac. Only this much. Niche ka part, this part of the intestine is within the abdomen. It's not inside the defect. So only part of the circumference of intestine. Part of circumference of intestine is in the defect. That is going to be a Richter's hernia. Okay, it is difficult to differentiate inguinal hernia from looking outside. Not at all difficult. Very easy. It will be above the groin crease. Inguinal hernia. Femoral hernia will be in the thigh. not in the abdomen. What is litter hernia? What is litter? Very good, Arpita. The content is Meckel's diverticulum. Obviously, not everybody will have Meckel's diverticulum. It's not seen in everybody. Medal hernia is this. It has two loops of bowel in the shape of an M. So medal will have two loops of bowel. What is amine hernia? What is amine? Appendix in a hernia, yes, where the content is appendix, but the hernia should be an inguinal. It should be appendix in inguinal hernia. कोई भी hernia नहीं, inguinal hernia का appendix होना चाहिए. So appendix should be as the content in an inguinal hernia. It will be called amine hernia. What is sliding hernia? Nobody understands this. Every time people ask me, sir, sliding hernia नहीं समझ में आता. A for appendix. You know, they will change it. They will give you appendix in a femoral hernia, and that is not amine. You know, लफड़ा हो जाएगा फिर. You will mark amine, but amine is only for inguinal. If it's a femoral hernia with appendix, it is not called amine. Oops, it is called something else. Yeah. So what is the sliding hernia? You can see it very well. Normally, in the hernia, you will have sac going in like this. You'll have contents inside it. But there are some organs like cecum, sigmoid colon, which lie over here. Cecum lies over here. Okay, it's not inside the peritoneum. So sometimes the cecum can also go out from the side. It's not going in the sac. Sac to yahan hai. This is the content. But you can see the cecum has come into the hernia from outside the sac. It has slid with the sac. That is a sliding hernia, where some retroperitoneal organs, they enter the defect. So they are in the defect, but they are outside the sac. Sac ke bahar hai. So when I open the sac, I will not see the cecum because it's not a content. So when I'll open the sac from here, यहाँ से मैं sac open करूँगा and I look inside, I will see the xylem. I won't see cecum. Cecum will be outside the sac. It is in the hernia, but it is not in the sac. Right? So that is going to be. Sir, when femoral hernia, what it is called? It has a difficult name. It is called D-garangos. D-garangos. It is a appendix in femoral. That is called D-garangos. So you can see it is not A for amine, A for D-garangos to nahi hai na. Oops. Lafda hai. All right. So you have all these named hernias, but really speaking, whatever is the content doesn't matter. What matters is it inguinal or femoral, and whatever is the hernia, there is only one treatment for hernia, that is surgery. Or भी treatment है ही नहीं. So what surgeries do we do for hernias? There are many surgeries, but you need to know the three main types. The first type is what is called as herniotomy. Herniotomy, you can simply understand as sac excision. You excise the sac. Only sac. Nothing is done to the defect. Nothing is done to the posterior wall. You just excise the sac. That's it. This can only be done in children with inguinal hernias. Children less than 18 years. If they have an inguinal hernia, only herniotomy is enough. Okay. If it's an adult like you, if you get an inguinal hernia, then one of these two has to be done. One is called herniorrhaphy. In herniorrhaphy, you make the inguinal canal wall strong. So you strengthen the inguinal canal. You strengthen the posterior wall with some adjacent tissue. Okay, there are those different types you may study in the books. Like there is a Bassini repair, Scholdice's repair, also known as Scholdice's double breasting repair. So you have Bassini, you have Shouldice's double breasting. There is a very nice Indian invention. Anybody knows the name? Yeah, Oppenheimer is ready-made with all the answers. That is called Desarda repair. This is Indian repair. What he does is he uses external oblique aponeurosis to strengthen the posterior wall. The Indian invention. But what is currently practiced is this. This is the treatment of choice. This is called hernioplasty. Where you are putting a mesh on the inguinal canal posterior wall, right? So you are using a Liechtenstein's mesh repair. So this is a mesh. The mesh is made of polypropylene. And this is what is commonly practiced nowadays. It's a polypropylene mesh. Common name of polypropylene? How do you know it commonly? Like polypropylene is the scientific name. Yeah. What do you call this? No, not polygalactin. Array, what is the common name of polypropylene? Answer is in the name itself. Plastic, no, it is also called as proline mesh. If you see in surgery wards, they will not call it polypropylene, they will call it proline. Proline is the trade name, like ethylene, micryl, proline. So it is a non-absorbable mesh. It will remain forever. All right. So these are the open hernia surgeries. In herniotomy, just excise the sac, done in children. Adults, herniorrhaphy means strengthen the posterior wall with adjacent tissue, or hernioplasty, strengthen the wall with a mesh like this. What is the most common complication of open hernia repair? So most common complication of open hernia repair is going to be chronic pain due to ilioinguinal nerve injury. Ilioinguinal nerve injury that will lead to chronic pain. When I say chronic, it means the pain should persist for more than 3 months. You don't need to know the details of these surgeries. Don't worry. I can draw it and show it, but it's not needed. So don't worry about it. Yeah, I can draw it and show it, but not so close to your exam. Don't worry about it. मतलब मैं बता दूंगा, but it will be a waste of time. आप भूल जाओगे, है ना? Unfortunately, I can teach it. I have no problem, but I don't feel it's needed at this stage. It's a little late in the day for that. So hernioplasty is what is the treatment of choice as of today. Liechtenstein hernioplasty with a polypropylene mesh. Alternate to Liechtenstein hernioplasty is laparoscopic repairs. So again, here you need to know the names. If you want to see, you can see it on the app, the different surgeries, but I really don't feel you need to know. So laparoscopic repair are done in 2 ways. One is called TAPP repair. Other is called TEP repair. In TAPP repair, I go into the abdomen. That is called as transabdominal preperitoneal. Transabdominal preperitoneal. That is called TAPP repair. In TEP, I don't enter the abdominal space. That is called as totally extraperitoneal. All right. Both surgeries essentially are the same. Just the way in which I begin the surgery is different. All right. Transabdominal preperitoneal, totally extraperitoneal. In both the surgeries, I use the same mesh. I place a proline mesh. दोनों में mesh same ही होगी. It will be a proline mesh and it will be placed preperitoneally. So it is a preperitoneal proline mesh same. But where I place it, it will be preperitoneal. The most common complication here is also going to be pain. But what nerve typically gets injured is going to be lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. So in the 2 repairs, open and laparoscopic repair, in open repair, ilioinguinal. In laparoscopic repair, lateral cutaneous nerve of thigh, because different nerves are encountered during the surgery. And then some landmarks in laparoscopy. One landmark is called triangle of doom. Okay, it's called triangle of doom. This is triangle of doom, where you have vas deferens medially and testicular vessels laterally. And within the triangle, you see these big artery and veins. So the content is going to be the external iliac vessels. They can get injured in this triangle, which is why it is called triangle of doom. Like if you traumatize the external iliac vessels, it will spell doomsday for the patient. So the content is going to be external iliac vessels in triangle of doom. Iliohypogastric कब injured होगी? Appendectomy. When I do the muscle cutting incision, Morrison's incision in appendectomy, it will get injured. It's normally not encountered in inguinal hernia repair. Meralgia is this lateral cutaneous nerve of thigh. This is called as meralgia paresthetica. Okay. Iliohypogastric nerve is a sensory motor nerve. It's a motor nerve. It gets injured in muscle cutting incision of appendectomy. So this is triangle of doom. The second triangle adjacent to it is your triangle of pain. जो उसके बगल में, this triangle, this one, this is your triangle of pain. What is the boundary of this triangle? It is just adjacent to it. So here you will have testicular vessels medially. So medially it is testicular vessels. And laterally it is this structure, inguinal ligament. So it is inguinal ligament laterally. And why it is called triangle of pain? This contains your lateral cutaneous nerve of thigh. So it has many nerves. So this lateral cutaneous nerve is one of the nerves in this triangle over here. So here it gets injured and that will give you meralgia paresthetic. ठीक है, आगे बात समझ में, कोई प्रॉब्लम नहीं है? Yeah, very good. Oppenheimer is our what do you say? He is our aggregator, like how you have Zomato app, which aggregates everything in one place. You want to order momos from whichever place, he will aggregate it. That's what our guy is doing here, Oppenheimer. नाम तो एटम बॉम्ब वाला है, पर काम उसके aggregator वाले. There are many aggregators, even in education, na? Something extra. He is one of those aggregators. You know who is going to emulate in the future. Yeah. Yeah. You will get lunch break at 2 o'clock. Don't worry. So far, we are going all right. तुम Zomato के डिलीवरी बॉय नहीं हो, तुम Zomato का ऐप हो. You are the app. सब तैयार रखा है उसने. Okay. So we have done many topics in GIT. Many topics in not even like 3.5 hours. So solve this question. Patient presents with herniation of intestinal loops which pass along the spermatic cord till it reaches the scrotum. If it is reaching the scrotum along the spermatic cord, that means spermatic cord aati hai deep ring se. Hernia is also going to come from the deep ring. Hernia that comes from the deep ring is going to be indirect hernia. Indirect hernia ही scrotum पे जाती है, direct hernia normally नहीं जाती है. So it will be indirect. Direct hernias are usually going to be only in inguinal region. They are called as bubonocele. A hernia only in the inguinal canal is called a bubonocele. Femoral hernia has nothing to do. It will be in the thigh. Right? Okay. So these are some of the important topics in HPB. Yeah. HD. Direct have cuffing reflex. No. Coughing is in all hernias. All hernias will have impulse on coughing. It's not only to do with direct or indirect. Any other classification you need to know? No, I don't think they will ask you any classification on hernias. I don't think. There is the one that I teach in NEET PG is called EHS classification. European Hernia Society. You can read it if you want. Niles Gilbert are very archaic. बहुत पुराने हैं. कोई नहीं करता. Nobody uses it. The one which is used is EHS classification. It is for inguinal, it is for ventral hernias also. Okay, these are some of the things which are absolutely must to know. You will get this in the PDF. You can see it that time. But I'll try to cover as many of these IMPs as possible. Now, when you study hepatobiliary, apart from individual diseases and some cancers, you should know this part, which is a little tricky. Because आजकल ना ये लोग पूछते हैं the scores and they are all very confusing. So I'll put it in a very simple way. The first score is the child score. In which patients do I use the child score? Child score is a score of prognosis. It's a score of severity, but in which patients? It is a severity score in whom? Yeah, ABCD is right, but किस में use करूँगा? It is a score of chronic liver disease or cirrhosis. So someone who has a chronic liver disease, someone who has a cirrhosis, in this patient I calculate the child score. Okay, and the components of child score, you know, A, B, C, D, E, because child learns A, B, C, D, E. These are the components. A is for albumin, B is for bilirubin, C is for coagulopathy, also called as PTINR. D is for distension or ascites, and E is for encephalopathy. This is a PYQ, by the way, components of child score. But more than that, please use it in someone who has cirrhosis of liver to tell you how bad is his cirrhosis. Early cirrhosis will be child A, advanced cirrhosis will be child C. So it gives you a score which is anything from 5 to 15. This will categorize the patient as based on the score as child A, child B, child C. Higher the score, more advanced. Okay, higher the score, more advanced is the chronic liver disease. Maximum is 15, huh? उससे ज़्यादा नहीं. What is this MELD score? MELD stands for Model for End Stage Liver Disease. अब नाम से आपको कुछ आइडिया आना चाहिए. Model for End Stage Liver Disease. This score also is like child score. It tells me the severity, but more than that, it tells me, is the person going to be suitable for liver transplant? Matlab, first the patient comes with cirrhosis. I do his child score. He is child B or child C, means he has advanced cirrhosis. Then I want to decide, should I give him a new liver? I calculate his MELD score. If the MELD score is above a certain value, that means if it is more than 15, then the person is a candidate for liver transplant. So how it is calculated, it's complicated. There are three components given by the mnemonic CBI. C is creatinine. Creatinine, not coagulation. Creatinine. B is bilirubin. I is INR. So ये तीन चीज से you calculate a score. It's a complicated score. But if the score is high, that means he qualifies for getting a new liver. The score should be more than 15. And there is no upper limit in this. Upper limit is infinite. Yeah. Nowadays, in the MELD score, they also add, so they have also added sodium. They also check the sodium levels as a part of the score. So CBI with sodium. So this score is also called as MELD ना. आप लोग बहुत ना लिखते हो ना conversation में. Sir ये पढ़ाओ ना, Woodsall rule बताओ ना. So this is MELD ना score. INR is international normalized ratio. It's a measure of clotting profile. Like how you do prothrombin time ratio is called INR. Right? It's like PTIR. So you check out MELD na score. What is King's criteria? ये कोई बताओ तो मैं मानूं. It's not very easy. What is this King's criteria? King, वो वाला king नहीं है. This King is the name of a college in London. It's called King's College. Hey, poisoning क्या? It tells me he has liver poisoning. No, no. ये होता है ना, P for poisoning, P for PCM, P for Kings. ऐसे पढ़ोगे तो ऐसे ही होगा. No. Someone has given the correct answer. Mohit Kumar, excellent. This tells me whenever you see criteria, what does criteria mean? If I get more than 150, I have fulfilled the criteria of passing FMG. Criteria means if I cross a certain limit, I get a prize. So King's criteria means if I cross a certain limit, I should get some reward. So King's criteria is a criteria to check your suitability, not for becoming MBBS. It's a suitability for getting liver transplant if I have acute liver failure. If I have acute liver failure, the commonest cause of acute liver failure is paracetamol poisoning. No doubt about it. But every patient with paracetamol poisoning is not going to get a new liver. If he fulfills the criteria, it's a complicated criteria, no need to know, then he gets a new liver. So it's a criteria for acute failure. So basically, child's and mild are chronic. King's criteria, acute liver failure. क्या मिलेगा? नया liver मिलेगा. And what is this Milan criteria? ये तो और भी अच्छा criteria है. No, biliary atresia. No, biliary atresia is not an acute condition. Yes, Pallavi, that's a brilliant answer. Milan criteria again is a criteria. It will tell me suitability for getting a liver transplant. But in a patient who should have cirrhosis, so cirrhosis to chahiye, but he should also have liver tumor, hepatoma. So if I have cirrhosis and I have a hepatoma, mind you, hepatoma is seen in patients with cirrhosis only, not metastatic. It should be seen in cirrhotic patients. In that case, he will get a new liver. So liver cancer with cirrhosis, if he fulfills the criteria, what is the criteria? The tumor should be a single tumor. Our aggregator has told us less than 5 centimeters. Or you can have maximum 3 tumors where each should be less than 3 centimeters. Then he can get a new liver. He fulfills the criteria. If it's more than this, sorry, tata, bye-bye, no liver for you. So these are all different criteria which tell you should you get. Sir, ये Milan parotid में भी था, पता नहीं मुझे. I have not heard of it anywhere else. Okay, so these are some of the criteria you need to know in liver disease. Now you know the concept, the perspective. Now if they ask you anything twisted, you will be able to answer because that clarity will be there. Individually, they are too hard to understand. Okay, answer this. फोन में नहीं, वो कॉपी पेस्ट कर रहा है दोस्त. Our aggregator is very advanced. He's copying pasting. He's not typing. It is too precise what he's writing. Miami Protocol. Oh, Milan. Hello. Milan, Italy. Inter Milan, AC Milan football teams. They are Italian teams. Miami तो पता है ना. To be in America. Yeah. So which of these are components? You have the ABCD. You have albumin, bilirubin, coagulation, distension, encephalopathy. Answer is B. All right. So that was liver criteria. Now you need to know this Todani classification. Very nice classification. Quite nice. It is used for a very nice disease, which is called as choledochal cyst. This choledochal cyst is a congenital cyst. Okay, it is present since birth. It is basically when some part of the bile duct is dilated. Those different parts which dilate is given by this classification of Todani, and there are 5 types. 2, 3. There is 4A, 4B, and there is 5. Type 1 choledochal, which you can see this. It is a fusiform dilation of CVD. Fusiform of CVD, common bile duct. Only the CVD is dilated, nothing else. In type 2, you can see there is a lateral dilation of the CVD. That is called diverticuli of CVD. Type 3 is the most interesting one. Have a good look at it. This is the CVD. Just the distal part of the CVD. This part is dilated. The part which is inside the duodenum. Intraduodenal CVD dilation, that is type 3. It is also called as choledochocele. Okay, it is the intraduodenal CVD dilation. The 4 and 5 are where multiple parts are dilated. It is not just CVD, CHD, intrahepatic ducts, all mixed. So 4 and 5 are diffuse types. In 4A, as you can see, this is 4A, CVD is also dilated, intrahepatic bile ducts are also dilated. So there is intra and extrahepatic bile duct dilation. A for and. In type B, only extrahepatic is dilated. Only extra. And in type 5, only intra. Type 5 is also called as Caroli's disease. Okay, it's also known as Caroli's disease. So these are the types of choledochal cysts. These cysts are there since birth. And whenever these cysts will dilate, typically it will present in a child. It is typically going to be seen in a young girl, younger than you are, young girl. And she will present with jaundice, obstructive jaundice. And there will be a palpable lump. So a young girl with obstructive jaundice with a palpable lump is likely to be a choledochal cyst. It is very common in Asians. It's common in Indian girls, 8-9-year-old girls. So they normally go to the pediatrician. They don't come to the surgeon. Then what will the pediatrician do if you present with jaundice and lump? Yeah. First step, LFT. Very good, very good. I'm happy. Don't refer. First do na. What if it is not choledochal cyst? So before you answer that, answer this. June 2022, someone was saying, sir, this is PYQ. What is the answer? So as you can see, this is CVD, just the distal terminal CVD is dilated. End part. So this is going to be type 3. Okay, this choledochocele. Any patient, whatever is the disease, if they present with any features of liver problems or biliary problems, irrespective of the disease, you will always start with LFT. This will be your first investigation. In this case, LFT will show you increased alkaline phosphatase because there is obstructive jaundice. So you see elevated alkaline phosphatase, you will see elevated direct bilirubin. Okay, so it tells you yes, it is obstructive jaundice, whatever is happening in the child. ऊपर वाला क्या है dilation के ऊपर? I don't know. And after that, you are going to do ultrasound, abdomen, to tell you yes, there is dilated bile ducts, and the investigation of choice is going to be MRC. All right. So be very clear about this pathway of investigations. Whenever you are dealing with any hepatobiliary disorder, you go in this pathway always. Gallbladder है ऊपर. अच्छा ये, oh, this part. Yeah, this is gallbladder. Oops. Gallbladder. It's there in the image. How did you understand he was asking this? मेरे को तो क्वेश्चन ही समझ में नहीं आया. अच्छा साइड में जो पाउच है. अच्छा he described it. No. Okay, just chill. So whenever you are thinking about obstructive jaundice or biliary diseases, if there is raised alphos, direct bilirubin, you do ultrasound, and after ultrasound, most of the times you will do MRCP. Okay, most of the sound you will do MRC. Most of the time you will do MRC. Okay. Now come to this. This is another very interesting disease. I hope you know this disease from a mile away. Yeah. So this is hydatid cyst, which is caused by a dog tapeworm called Echinococcus granulosus. Okay, that is the definitive host, dog. So dog tapeworm, Echinococcus granulosus. The definitive host is dog. Man should not get infected. Okay, the intermediate host is the sheep. If man gets it, it is a dead end in man. Okay, man should not get it. The man is the accidental host or the dead end host. Typically, the hydatid cyst will form in the liver. That's the most common site. So you get these cysts like this in the inferior part of the liver. एक दो cyst होंगे ऐसे. And within the cysts, you get smaller cysts, daughter cysts. All this is seen on imaging. Normally, this will be diagnosed by chance. Patient does not have any symptoms. So it will be found either on ultrasound like this. This is called as floating membrane sign, also called as water lily sign. Or you get this appearance. What is this image and what do you see? In this image, albendazole. C3AB, water lily, Kharbi. Oh, yeah, this is called, you see these white lines, they are septations. So you see multiple septations. That is very typical of hydatid cyst. You see multi-septate. If there are too many septa, it will look like a honeycomb. So these are all signs that you see on hydatid cyst on imaging. How do you treat hydatid cyst? Does every hydatid cyst require treatment? Train? No. Okay. So to know whether to treat or not, you see the imaging finding. If it is calcified, you need to do nothing. If it's calcified, then no treatment. If it is active, okay, or it is in transition, all this is seen on imaging. This is the WHO classification. If it is active or transition, the first thing you are going to do is give albendazole. And after giving albendazole, you have to decide about the treatment. So you have two treatments available. Either you can do the radiological way, which is called pair procedure. This is radiological, or you can do surgery. Right? Pair stands for puncture, aspiration, injection, reaspiration. Full form pe dhyan dena. This puncture word they will change and they will write percutaneous. It's not percutaneous, it is puncture. You do puncture, aspirate, you inject, you reaspirate. All right, that is what is done in pair. How do you choose whether to do pair or whether to do this? How do you decide what to be done? So pair is the preferred treatment. Where you can't do pair, you will do surgery. So you should only know contraindications for pair. Wherever possible, do pair because pair is non-surgical. The contraindications are if it is a multiseptate. Because multiseptate, honeycomb cysts, you are not going to be able to puncture each and every part. So multiseptate cysts, deep cysts, which can't be reached, deep-seated, or a cyst which is communicating with the bile duct, cystobiliary communication. Only in these cases where you can't do pair, you are going to go for surgery. So where pair is contraindicated, you do surgery. Treatment of choice is pair. Okay, surgery is removal of the cyst, which is called pericystectomy. Absolutely right. Not pericolectomy, pericystectomy. So the surgery is going to be pericystectomy, but it doesn't mean you do it in every case. Only where you can't do pair, you are going to do pericystectomy. Okay. Now come to an important topic, bile duct injury. I'll explain it in a very simple way. एक बार ये टॉपिक समझ गए ना, आपका सारा HPV इसी में हो गया. This is the most important part of HPV which people don't really understand. So we will do it in a very simple way. Bile duct injury normally happens during cholecystectomy. आज के जमाने में during lap chole. So when I am removing the gallbladder, that is when there is a chance that I may injure the biliary tree. Now, what will get injured? So little anatomy I will tell you, then you will understand it very simply. I have two ducts which come out from the liver, left and right duct. They come together, they form the common hepatic duct, CHD. This common hepatic duct will receive the gallbladder duct, cystic duct, and then it will form the CBD. This is the CBD, common bile duct. This CBD will go into the duodenum like this. All right. When I am doing lap chole, this is again from one of my Insta stories, which many people made a mistake in. I am doing my surgery mainly in this area. This is the area of surgery. What is this area called? Where I do the cholecystectomy, the main area of dissection. It is called Callet's triangle. Okay, that is the area where I dissect, Callet's triangle. If there is some inflammation or problem in the Callet's triangle, I can injure some of the ducts over here. Now, what ducts can I injure? I can injure this duct, cystic duct. I can injure this duct. This is the right hepatic duct or right posterior duct. Or I can injure this duct, CHD. CBD injury होना मुश्किल है. Left duct injure होना मुश्किल. It's hard. So the three common things, many people said भूल से click हुआ. भूल से कुछ नहीं होता. Normally, one of these three ducts can get injured: cystic duct, common hepatic duct, or right posterior duct. If they get injured, they can get injured in two ways. Either you cut it by mistake. So one of the ways of injuring them is going to be acute injury. Acute means you cut the duct and you didn't realize it. So there is acute injury. And when there is a cut acutely, this will lead to leakage of bile. So the bile will start leaking. Whichever duct you cut, bile will start leaking out. So there is leakage of bile. On the other hand, if by mistake you didn't cut it, you just burnt it. You thought it was some artery and you burnt it. So when you burn it, it will not leak. But over time, it will become narrow. It will get fibrosed. This will lead to chronic injury. Chronic means you burnt it. गलती से. And when you burn it, it will get strictured. बस इतना ही समझना. If you understood this part, na, the whole freaking bile duct injury you understood. Acute bile duct injury, bile duct is cut, bile will leak. Chronic injury, over time, it will narrow, causing an obstructive jaundice. Rest of the part is easy. When the bile leaks, how will the person present in acute bile duct injury? So in acute, there will be history of lap chole. And this history will be maybe 1 or 2 days back. कल परसों bile duct, मतलब कल परसों cholecystectomy हुई. He is either still in the hospital or he just got discharged. And after this bile duct injury happened, which you didn't realize, and the bile starts leaking, the bile will leak over here. Whichever thing was injured, the bile starts leaking and starts getting collected here. This collection will cause him pain. He may get fever. This is because of this bile which is leaking. He may get peritonitis also. Any patient after cholecystectomy, within 1 or 2 days, if he gets these kind of symptoms, you are worried. Shit, you cut the bile duct. Oh gosh, now it's a disaster. When you do this, when he comes with 1 or 2 days later with pain, fever, he has right hypochondriac tenderness. You are like, oh God, what have I done? What is the first thing you are going to do? You will tell him, boss, please come back. I will investigate. The first step is you want to know that bile is leaking and collecting over here. So to identify this bile collection, you will do ultrasound or you will do CT abdomen, which will show that yes, there is a collection. If you see bile collection, any kind of collection, you know there is a bile duct injury. It has to be managed. So what are you going to do is what is called as the SNAP protocol. Means first, this collection has to be drained. That is called sepsis control. So you have to remove whatever bile is leaking. Where it is leaking from, I don't know. But this pus or bile which is collecting has to be drained out. So I can put a drain and take it out, or I can do surgery and take it out. But the bile has to be taken out. So the first step for sepsis control is going to be either I put a pigtail to drain the bile, or I do surgery. Only to drain the bile, not to fix the injury. Then I give him some nutrition, which you guys also need right now. Some nutrition will be given so that he becomes healthy. And then I want to know where is the bile leaking from. Anatomy of injury. Anatomy or site. Is it cystic duct? Is it common bile duct? Is it common hepatic duct? Is it right posterior duct? For this, I can either do MRCP or I can do ERCP. Different books give different answers. My answer would be MRCP first, but you can do either. You can do MRCP, you can do ERCP. If both are there in the option, my suggestion would be MRCP, but there is nothing hard and fast in this. Okay. So you come to know where it is leaking from. And based on where it is leaking from, you will do a planned repair. Okay, you will do a planned repair. Now, what is this planned repair? It depends on this type of injury. All this. This is given by Strasbourg, where you have type A, type B, type C, type D. Type A means it is leaking from cystic duct. If it is leaking from cystic duct, you will do ERCP and stenting. This is the treatment of choice. If it is leaking from cystic duct, just do ERCP and stenting. You put a stent in the CBD, the leak will stop. Nothing needs to be done. Type B is a little different. In type B, there is no leak. The duct is blocked. So it is a blocked right posterior duct. This duct. It is blocked. By mistake, you tied it. So in type B, there is no leak. In type C, you by mistake cut the right posterior duct. So obviously here there will be leak. This is dangerous. And in type D, you cut the common hepatic duct. All of these three will be repaired later. Repair after 3 months. Okay. Normally 2 to 3 months later, once the patient becomes okay, you will repair it. How you repair is immaterial, but it has to be repaired later. Only the cystic duct leak, you put a stent, the job is done. But for other leaks, you can't treat them immediately. Wait, let the patient become okay, wait for a few months, then do the repair. That is called planned reconstruction. Yes, someone said something. Someone called out to me. Did you hear it or am I imagining it? Someone did call out to me, na? Sir karke. Yes. It means let them go, Shubham Bhaiya. I will let you go. Just last part is left. So if it is acute bile duct injury, SNAP protocol. Drain the collection, anatomical delineation, depend on the Strasbourg, you do the repair. Chronic will present very late. Chronic will present months or years later. Some months or years after cholecystectomy, where the person will present with obstructive jaundice. So he will present with jaundice. He will present with pruritus. He will present with clay-colored stools, dark-colored urine, and so on and so forth. So it will come after some time. It won't be acute. In this case, what are you going to do first? Obstructive jaundice, first do LFT, then do USG. LFT will give you a picture like this that you got in choledochal cyst, same this kind, raised alphos, raised direct bilirubin, because there is a narrowing. Then you want to know where is the narrowing. To know the location of the injury, you will do MRCP. Obviously, this is the investigation of choice. And after MRCP, you are going to do a reconstruction. So wherever is the stricture, you have to reconstruct it. So simple. So chronic bile duct injury is fine. It narrowed over time, you have to repair it. Acute bile duct injury is life-threatening. It can kill him very fast if you don't do sepsis. Yeah, that was about bile duct injury and the different types. Answer this question, then I'll give you a break. Your lunch break comes then. Patient has undergone cholecystectomy. He presents with upper abdominal pain. What are you going to do? See, they asked this question. Really speaking, they should not have asked. It's a little high level question. It's not really FMG or even NEET PG level, but they are asking. So if there is a leak from cystic duct stump, the Strasbourg type is type A. This is actually the most common type, and the treatment is ERCP and stenting. All right. Okay. What is this? According to Strasbourg, leak from an aberrant right posterior duct. What type is this? So if there is leak from right posterior duct, it is type C. It was cut. If it was just blocked, it would be type B. Okay, B for blocked, C for cut. Yeah, fine, good. Okay, so have your lunch break. There is very little left in hepatobiliary. We'll finish that and then we'll go to the other parts. So your lunch break is still 2:45. 2:45, please come back. Then we will finish the rest. Yeah, D is common hepatic duct injury. Absolutely right. Common hepatic duct leak. Okay, 2:45, come back.